Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our Mrcp Part 2 RCP sample paper discussion. Before starting the session, let me share the most important info. The greatest challenge in your Mrcp Part 2 exam is that the question structure and their difficulty level does not match with the traditional 3 question bank like the past medicine, past test, or BMC on examination. It has got slight similarities with the past papers, but the real exam scenario are much more complicated, twisted, and confusing. So, how can you get an idea on the question structures? It is the RCP sample paper which is most identical to the real exam. You will have either the similar type of question pattern like this, or there would be comparatively tougher. And for every MCQ, you will be needing to analyze and apply the exclusion theory. So it's mandatory to go through the RCP sample paper in the best possible manner before your exam and revising at least twice. If you neglect them, you will regret in the long run. So let's get started with our original discussion.
What therapy is most likely to correct the calcium and parathyroid hormone concentrations? Alendronic acid, alpha calcidol, calcitonin, cinacalcet, ergocalciferol. 67-year-old woman was referred with a 3-month history of painful legs, malaise, and weight loss. She had type 2 diabetes, mellitus, and hypertension for 18 years. Her medication was gliclazide 160 mg twice daily, Ramipril 2.5 mg daily, and atorvastatin 20 mg daily. On examination, her BP was 145 over 90 millimeters mercury. She had some tenderness over her spine and legs. Serum sodium is 138, potassium 5.5, creatinine 240, corrected calcium 1.80, EGFR 19, serum phosphate 1.6, plasma parathyroid hormone 22.2. What therapy is most likely to correct the calcium and parathyroid hormone concentrations?
So, what is the most likely diagnosis?
Secondary hyperparathyroidism.
Also, let's go for the general rule. So, primary hyperparathyroidism will always have the normal renal function test. If there is renal impairment, then primary hyperparathyroidism is excluded. The parathyroid hormone is directly proportional to calcium, inversely proportional to phosphate. So, in primary hyperparathyroidism, there would be elevated PTH, elevated calcium, and there would be reduction in the serum phosphate. And alternatively, secondary and tertiary hyperparathyroidism will always have the deranged renal function test. If there is normal renal function test, secondary and tertiary hyperparathyroidism are excluded. To differentiate between secondary and tertiary hyperparathyroidism, we need to look at the serum calcium level. In case of secondary hyperparathyroidism, there would be hypocalcemia, and in case of tertiary hyperparathyroidism, there would be hypercalcemia. So this patient presentation along with the laboratory findings suggests that the secondary hyperparathyroidism due to the CKD, chronic kidney disease. And if we analyze the key findings here, patient is having the elevated plasma parathyroid hormone level 22.2 picomole per liter, which is elevated. Patient is having the features of hypocalcemia, and patient is also having the elevated serum creatinine and the reduced EGFR, pointing towards the advanced CKD. So in case of CKD, the kidney's ability to convert vitamin D into its active form, calcitriol, this is impaired, leading to hypocalcemia. And hypocalcemia, in turn, it will stimulate the parathyroid gland to produce more parathyroid, leading to secondary hyperparathyroidism. So this condition will ultimately require treatment to correct the calcium deficiency and reduce the parathyroid level. So considering secondary hyperparathyroidism, which therapy would be most appropriate for the correction of calcium deficiency and reduction of PTH level? So
Alpha calcidiol.
if we go for the laboratory finding analysis, so this patient is having the elevated serum creatinine and the reduced eGFR only 19 millimole. So these values indicate that there has been a significant renal impairment consistent with the stage 4 CKD, and the kidney's ability to filter the waste product and manage the electrolyte balance is severely compromised. And patient is also having the features of hyperkalemia. So the elevated potassium, this is likely due to the reduced renal excretion, which is more commonly seen in case of advanced CKD. And this hyperkalemia can also contribute to the malaise as well as the muscle weakness. And the low calcium level, this is a direct consequences of CKD. The kidneys convert vitamin D into its active form, which is essential for the calcium absorption from the gut. And with reduced calcitriol, the calcium level will be ultimately dropped, and the patient will comes up with the features of hyperphosphatemia. The kidneys usually excrete phosphate. In CKD, the phosphate will be building up in the blood, which will further lower the calcium level through precipitation of the calcium phosphate complexes, and it will further inhibit the calcitriol production. And the parathyroid gland, they will respond to hypocalcemia by increasing the PTH secretion. So this condition, this is known as the secondary hyperparathyroidism, which is common in case of CKD, and in this case we are having the CKD stage 4. So in case of CKD stage 4, there would be impairment of the vitamin D metabolism, there would be phosphate retention, and ultimately there would be features of secondary hyperparathyroidism. So if we analyze the treatment options, so this alendronic acid, this is the bisphosphonate used to treat the osteoporosis by inhibiting the osteoclast mediated bone resorption. So it will help to manage the bone density, but it will not address the hypocalcemia or hyperparathyroidism, and it can also causes worsening of the hypocalcemia in this patient. Alpha calcidol, so this is the synthetic vitamin D analog that is hydroxylated and making it active without requirement for the renal conversion. And this alpha calcidol, it increases the intestinal absorption of calcium and phosphate, and it will also help us to normalize the serum calcium level and reduce the parathyroid secretion by the negative feedback mechanism. So this will be the most appropriate management in this patient. It will address the root cause of secondary hyperparathyroidism in CKD, and it would be the most appropriate treatment in this scenario. Regarding calcitonin, so this is a hormone. It will reduce the blood calcium level by inhibiting bone resorption and increasing the renal excretion of calcium, and this would be counterproductive in this patient with hypocalcemia. This is not indicated here because the patient is having hypocalcemia, not hypercalcemia. It will causes further reduction in the calcium level. And next one is our cinacalcet. So this is a calcimimetic drug that enhances the sensitivity of calcium sensing receptor in the parathyroid gland, which will ultimately causes reduction in the PTH secretion. So it is useful in controlling the hyperparathyroidism, but it will not address the underlying hypocalcemia. This is also not the first line treatment for the metabolic abnormality seen here. Next one is our argocalciferol. So argocalciferol, this is the vitamin D2, and it requires conversion by the kidney to its active form, and it would be impaired in case of CKD, and it will also be less effective in managing the calcium and phosphate metabolism in this patient. So ultimately, the most suitable choice of treatment would be the alpha calcidol. Uh, what is the most common adverse effect of cinacalcet? Commonest adverse effect? Cinacalcet is a calcimimetic acting on the calcium sensing receptor on the parathyroid gland, used for patients with hyperparathyroidism who are on dialysis or for whom surgery is not an option. So this cinacalcet is the calcium sensing receptor agonist. Cinacalcet is indicated for the treatment of hypercalcemia in patients with parathyroid carcinoma unsuitable for parathyroidectomy, or for secondary hyperparathyroidism in patients with CKD who requires dialysis. And one of the most common adverse effects of cinacalcet is the drug-induced hypocalcemia. It will lead to drug-induced hypocalcemia. Cinacalcet may be used in patients with ESRD receiving maintenance hemodialysis with frequent monitoring of parathormone and the calcium. So this alpha calcium, it would be the most appropriate therapy because it directly corrects the hypocalcemia and reduces the PTH level, and it will also address the underlying disturbances in vitamin D metabolism seen in patient with CKD. And this is the active form of vitamin D analog that bypasses the need for renal activation and helping it to increase the calcium absorption from the gut, correcting the hypocalcemia and subsequently reducing the PTH level. And by improving the calcium absorption and reducing the secondary hyperparathyroidism, alpha calcium, it will target the pathophysiological mechanism contributing to this patient's symptoms and the laboratory abnormalities.
What is the most appropriate management? Biopsy of liver lesions, palliative chemotherapy, palliative radiotherapy, staged surgical resection of carcinoma and liver lesions, stenting of colorectal carcinoma. 52-year-old man presented with a 4-month history of altered bowel habit with occasional bright red blood per rectum. Colonoscopy showed annular sigmoid tumor, and histology confirmed an adenocarcinoma. Staging CT scan showed 2 adjacent 1 centimeter lesions in the right lobe of the liver, highly suspicious for liver mets. What is the most appropriate management?
So this 52-year-old man presents with the 4 months history of altered bowel habit, occasional bright red blood per rectum. These symptoms led to colonoscopy, which leads an annular ring-shaped tumor in the sigmoid colon, and histology confirmed this tumor to be an adenocarcinoma, uh, which is a common type of CRC, colorectal cancer. And the staging CT scan, it reveals that 2 adjacent 1 centimeter lesion in the right lobe of the liver, which are highly suspicious for the liver metastasis. And the liver is usually the most common site of metastasis for the colorectal cancer due to the venous drainage of the colon through the portal system. The diagnosis of adenocarcinoma of colon with suspicious of the liver lesion, it indicates that the patient is most likely having the stage 4 colorectal cancer, stage 4 CRC. And and in the presence of a liver limited disease, meaning in presence of metastasis confined to the liver, this is an important factor in deciding the treatment approach. And if the metastases are resectable, then the disease can still be potentially be cured. And regarding the treatment objective in case of CRC, coming up with stage 4 with the liver limited metastasis, so our primary goal would be to achieve the curative outcome if possible, given the potentially resective nature of the both primary tumor and the liver metastasis. And this curative treatment, it involves the complete surgical removal of all known tumor site. So if we analyze the treatment option, so biopsy of the liver lesion. So biopsy might be considered if there was uncertainty regarding the nature of the liver lesion. However, given the strong clinical and the radiological suspicion, the lesions are highly suspicious of the metastasis. So, biopsy may not change the management plan, and it won't be the most appropriate initial step. If the imaging strongly suggests metastasis in a patient with a known primary colorectal cancer, proceeding to treatment rather than biopsy is generally preferred unless the nature of the lesion is doubt or there is a need to differentiate from other potential pathologies. But here the diagnosis is pretty much confirmed. Regarding palliative chemotherapy, so this palliative chemotherapy is typically offered to patients with a widespread metastatic disease, to those patients who are not suitable for surgery, or if the disease burden is too high for the curative resection. While chemotherapy can control the disease progression and alleviate the symptoms, but this is also not the first choice in a potentially resectable cases. Chemotherapy can be used as a neoadjuvant, meaning before the surgery, to shrink the tumor, making the surgical resection easier and more effective. But the main focus will be on the curative resection if this is possible. Regarding palliative radiotherapy, so this is also generally not used as an primary treatment for liver metastasis in a patient with CRC, especially in the potentially resectable cases. It may be used for the symptomatic control in some of the specific situation, like in case of bony metastasis or a rectal tumor causing the local symptoms. And this is not also the curative management for the liver metastasis. This is usually more appropriate in unresectable disease, or where we are just going for the symptomatic relief. And the staged surgical resection of the carcinoma and the liver lesion. So this is the most appropriate management for this patient with a resectable liver metastasis and a resectable primary tumor. And surgical resection of both the primary tumor and liver metastasis, it will offer us the best chance for a curative outcome as well as a long-term survival. And this staged surgical resection, it can either be done simultaneously or it can be done in a staged manner, meaning resecting the primary tumor first, then followed by the liver metastasis, or vice versa. So in case of simultaneous resection, both the primary and the liver metastasis, they are usually removed in a single surgery. And this approach can reduce the overall treatment time and avoid progression of the metastasis while waiting for the second surgery. And in case of staged resection, it usually involves first removing the primary tumor, followed by a period of recovery, and then performing the liver resection. And staging this staged resection, this is more beneficial if the patient's overall health, the complexities of the surgery, or the extent of the disease suggests that two separate surgery might be safer. So this factor would be dependent on overall the patient's health, the extent of liver disease, and the complexities of the surgery, and also the response to any neoadjuvant therapy. So we can either go for simultaneous resection or we can go for staged resection. But since this is resectable, so the highest degree of outcome it can be achieved through the staged surgical resection of carcinoma and the liver lesions. And regarding stenting of the colorectal carcinoma, so colorectal stenting, this is typically reserved for cases of bowel obstruction, where our ultimate aim would be to relieve the obstruction, and it will allow for either palliation or to bridge for surgery. And in this scenario, there is no evidence of bowel obstruction, so stenting is not indicated. So the most appropriate management for this patient is the staged surgical resection of carcinoma and the liver lesion, and it will aim to achieve the curative resection by addressing both the primary tumor and the liver metastasis, and it will also offer us the best chance for a long-term survival. And in some cases, following the staged surgical resection, we can also go for the neoadjuvant chemotherapy as an adjunctive therapy. But the primary treatment here will always be the staged surgical resection of carcinoma with the liver lesions. Sorry, we are skipping the explanation. Okay, for the first one. This patient has a raised serum creatinine with hypocalcemia and a raised serum phosphate. This pattern is consistent with CKD with impaired renal phosphate secretion and deficient activation of vitamin D, leading to impaired gut absorption of calcium and hypocalcemia. The raised plasma parathyroid hormone is due to secondary hyperparathyroidism in an attempt to restore the serum calcium concentration to normal. The leg pain is arising from the renal bone disease. The correct answer is alpha calcidol. Correction of vitamin D deficiency is the key to restoring a normal calcium homeostasis and must be with alpha calcidiol 125 hydroxycholecalciferol, which replaces the deficient activation step in CKD. Argocalciferol cannot be activated in CKD. And regarding second one, historically, the presence of liver metastasis complicating colorectal carcinoma would have meant inoperable disease. However, in selected cases, a 5-year survival rate of up to 30% may be achieved by resection of the primary colonic tumor and liver metastasis. Biopsy of the liver lesion would potentially seed the tumor and render the patient inoperable.
What is the most likely pathogen? Cryptosporidium parvum, Entamoeba histolytica, Giardia intestinalis, Pneumocystis jirovecii, Toxoplasma gondii. 53-year-old man presented with a 2-week history of diarrhea associated with cramping abdominal pain. He was passing up to 15 very loose and watery stools per day. He had no blood in his stools. He had undergone a heart transplant 2 years previously, and his medication comprised cyclosporin, prednisolone, aspirin, and ramipril. Hemoglobin is 110, WBC 12.5, serum urea 14.4, serum creat 135, CRP 35, stool culture shows negative, stool microscopy shows cyst identified on modified acid-fast stain. What is the most likely pathogen?
So this 53-year-old man who has a heart transplant 2 years previously and is on immunosuppressive therapy, cyclosporin and prednisolone, and presents with a 2-week history of severe diarrhea, cramping, abdominal pain, and there is no blood in the stool. So still microscopy reveals cyst identified on the modified acid-fast staining, and the stool culture is negative. So if we analyze the investigation, so patient is having mild anemia which could be related to either chronic disease or malnutrition from prolonged diarrhea, or it may be due to the renal dysfunction. The white cell count is slightly elevated, possibly indicating either there is an inflammatory or infectious process. Serum urea level and the serum creatinine levels are elevated, which indicates the renal impairment, which may be either secondary to dehydration from excessive diarrhea, or it may be due to the cyclosporin nephrotoxicity, or it may be related to underlying kidney disease. The serum CRP level is also elevated, indicating a significant inflammatory response consistent with an infectious process. The stool culture is negative, so this is excluding the common bacterial causes of diarrhea such as the salmonella, shigella e coli, or the campylobacter, and this is driving our attention towards the parasitic infection that causes the diarrhea. And this stool microscopy, the identification of cyst, this is the key finding. The modified acid-fast stain, this is specifically used to detect certain protozoal parasite, and particularly those who are the acid-fast, meaning they will retain the red dye used in the staining process. And this patient is also having the immunocompromised status. The patient is immunocompromised due to his heart transplant, and is also having the ongoing immunosuppressive therapy, both cyclosporin and the prednisolone, making him susceptible to the opportunistic infection. So given the patient immunocompromised state, the presentation of watery diarrhea and the identification of a cyst on a modified acid fast staining, so what should be the most likely pathogen?
Cryptosporidium.
Yes, this is the Cryptosporidium parvum. Cryptosporidium parvum, this is the most common cause of infective diarrhea in the immunocompromised patient, meaning either in case of AIDS or those who are taking the immunosuppressive drug. So this is one of the protozoal disease that commonly causes the chronic profuse diarrhea in the immunocompromised individual, including those who take the immunosuppressive therapy post-transplant. And this is usually detected using the modified acid fast staining, which will highlight the oocyst in a stool sample. So how to treat a case of cryptosporidiosis?
Hydrofoxamide drug, something like that.
In
Or
case of
spiromycin.
in case of immunocompetent patient, how will you treat the cryptosporidiosis?
Supportive treatment.
Yes, you'll just go for the supportive treatment. And in case of immunosuppressed patient,
Nitazoxanide.
yes, the first line is the nitazoxanide. Alternative, yes, you can go for
Rifaximin.
not rifaximin. This is yes, sorry, yes,
Spiromycin.
this is rifaximin. Yes, this is rifaximin. So if you go for the modified Chel-Nielsen stain, this is also known as the AAB stain, you will get the red cyst, and this is cardinal features of cryptosporidiosis. Nitazoxanide may be used to treat immunocompromised patient with cryptosporidiosis. And rifaximin, this is rifaximin, this is not rifampicin. Rifaximin is also sometimes used in immunocompromised patient or patient with severe disease. So if you go for the modified Chel-Nielsen staining, you will get red cyst, and you will first line choice of treatment in immunocompromised would be nitazoxanide, and rifampicin can also be used. Cryptosporidium is the most common infective cause of diarrhea in HIV patient. Cryptosporidium parvum infection can result in severe cholera-like diarrhea syndrome, and Cryptosporidium cyst turns red following the acid fast staining. So regarding Entamoeba histolytica, so it will causes the bloody diarrhea, preferably dysentery or hepatic abscess, and it will have a long incubation period, and it won't be identified on a modified acid fast staining. Giardia intestinalis, it will causes giardiasis, and patient will comes up with the features of malabsorption like the fatty stool, staturia, weight loss, flatulence, rather than the profuse watery diarrhea. And it will also comes up with the long incubation period greater than 7 days. The cyst of Giardia intestinalis can be seen in stool, but they are not usually detected using the modified acid fast staining. Pneumocystitis jirovecii, it will causes pneumonia. The pneumonia in the immunocompromised individual, especially in a patient with low CD4 count. And the exercise induced desaturation, this is the hallmark of PCP. And this pneumocystitis jirovecii, it does not usually causes the gastrointestinal symptoms, and this is also detected in the respiratory sample, not in case of stool. Toxoplasma gondii, it will causes toxoplasmosis, which will usually manifest with the neurological symptoms or with the features of chorioretinitis in a immunocompromised patient, and this is also not associated with diarrhea, and it will also not be detected in the stool microscopy. So the cardinal features of Cryptosporidium parvum would be severe and profuse chronic watery diarrhea. Patient will have the profuse, severe, chronic watery diarrhea in the immunocompromised patient, and it will lead to the significant fluid loss, dehydration, and even can lead to the renal impairment as well as the electrolyte imbalance, and the ongoing inflammation and damage to the intestinal lining. It will also causes the cramping abdominal pain, and patient will also comes up with the features of weight loss and malnutrition. And this condition, it exclusively occurs in the immunocompromised patient. So either the patient will be having the HIV, or the patient has already received the transplantation or having the ongoing immunosuppressive therapy. Other than this, it can also be seen in case of chronic disease or in severe comorbid condition. And regarding the diagnostic evidence, we need to go for the modified acid fast staining. So how to manage a case of Cryptosporidium parvum? Other than antiparasitic therapy, you need to go for the rehydration. Either you can go for the oral rehydration solution, or you can also go for the IV fluid. And for the antiparasitic therapy, the first line choice is the nitazoxanide. You can also go for rifaximin. And in some textbook, they also say you can also go for the paromomycin. And this paromomycin, this is the aminoglycoside antibiotic. So it would be the Cryptosporidium parvum. The protozoan Cryptosporidium parvum is the common cause of infective diarrhea. In healthy person, it usually causes a self-limiting illness. However, in the immunocompromised, it can cause severe prolonged diarrhea, and treatment is very difficult. Cryptosporidium parvum is diagnosed by performing an acid fast stain on feces and demonstrate the characteristics of this microorganism. In severely immunocompromised patient, pneumocystitis jirovecii typically causes pulmonary infection. Toxoplasma gondii causes cystic brain lesions. Entomobia histolytica, Giardia intestinalis are both intestinal protozoa, but they are not detected by the acid fast staining method. Entomobia histolytica causes dysentery. Giardia intestinalis causes flatulence, staturia, abdominal pain. So both Entomobia histolytica, Giardia intestinalis, both of them will have a long incubation period greater than 7 days. Both of them are commonly found in the Indian subcontinent, and both of them are treated with the same drug. You can either go for 7 days course of metronidazole or 7 days course of tinidazole. In case of Entomobia histolytica, patient will have bloody diarrhea. In case of Giardia intestinalis, patient will have non-bloody diarrhea with features of malabsorption.
What is the most likely cause of a renal impairment? Myelidosis, crescentic GN, IgA nephropathy, membranoproliferative GN, membranous nephropathy. 82-year-old woman with hypertension presented with a 6-week history of tiredness, ankle swelling, and arthralgia. On examination, her pulse was 92 beats per minute and her BP was 150 over 90 milliliters mercury. She had bilateral ankle edema. Her serum create concentration had been normal 6 months previously. Urine analysis showed blood 2 plus and protein 2 plus. Hemoglobin is 103, WBC 10.5, platelet count 410, serum create 252, and eGFR was 17. What is the most likely cause of a renal impairment?
So this 82-year-old woman with a history of hypertension presented with a 6-week history of tiredness, ankle swelling, arthralgia, and on examination, her pulse rate is 92 beats per minute, blood pressure is 150 by 90. Patient is having the bilateral ankle edema. Her urine analysis shows significant hematuria and significant proteinuria, but this is not within the nephrotic range proteinuria. This is not within the macroscopic hematuria. And the laboratory investigation is showing the features of anemia, there is elevated white cell count and elevated platelet count, significantly elevated serum creatinine level, and a markedly reduced EGFR, and her creatinine was previously normal 6 months previously. So there is a very rapid reduction in the renal function, evidenced by a significant increase in serum creatinine and a severe reduction in the EGFR, which suggests either this is a case of acute or rapidly progressive kidney injury. And the urine analysis is showing both the presence of blood and protein in the urine. So it is pointing towards the glomerular pathology. So significant proteinuria and the hematuria, it indicates there is glomerular damage rather than a purely tubular issue. Regarding anemia, this is commonly found in a patient with CKD, but anemia in this context is more likely to be due to chronic inflammation, which may be further related to either systemic vasculitis, which usually causes inflammation leading to reduction in the hemoglobin, or it may be a product of decreased erythropoietin production by the damaged kidney. And there is also leukocytosis and elevated platelet count, and they also reflect the underlying inflammatory or the autoimmune process. And regarding clinical symptoms, so there is a combination of tiredness, ankle swelling, arthralgia, or renal dysfunction in an elderly patient. It usually raises the concern of an underlying systemic vasculitis or an autoimmune process affecting the kidney. The edema, it may be a result due to proteinuria and the decreased kidney function. A patient may develop significant edema, and as seen in this patient with the bilateral ankle edema. Patient is also having the hypertension. So high blood pressure, this is common due to the kidney's impaired ability to regulate the fluid balance. So given the clinical presentation and laboratory findings, what is the most common cause of our renal impairment?
Crescentic.
Yes, this is the crescentic gene. So what are the differential diagnosis of crescentic glomerulonephritis?
Vagus granulomatosis, PASTEST.
And third one?
MPA.
Also, whether this is crescentic gene or RP gene or renopulmonary syndrome, all the three conditions, they are classically associated with three differential diagnoses. Number one, GPA, also known as Wegener's. Number two, MPA. And number three is the GPS, also known as anti-GPM antibody. And if you consider the fourth differential, it would be CSS, Sharp-Strauss syndrome, also known as the EGPA, but this is less commonly encountered. Usually the top three differential would be the GPA, MPA, and the GPS, good posture syndrome. Also, in a patient with rapidly progressive glomerulonephritis, in this scenario, patient is having the features of RPGN. So if you go for the renal biopsy, you will get the features of crescentic glomerulonephritis. And all the three top differentials, GPA, MPA, GPS, they are commonly associated with the features of RPGN, rapidly progressive glomerulonephritis. They are also related to renopulmonary syndrome, and they are also related to the crescentic glomerulonephritis. So the causes of RPGN, good posture syndrome, ANCA positive vasculitis, so either a GPA or MPA. So how can we differentiate between GPA, MPA, and GPS? Which one will have ENT involvement?
GPA.
So
GPA.
GPA will have the ENT involvement. Which one is related to C ANCA positivity?
Vaginous.
GPA.
Yes,
GPA.
GPA or vagus is related to C ANCA positivity. Which one is related to P ANCA positivity?
MPA.
MPA.
And which one would be ANCA negative?
GPS.
GPS.
Yes, GPS is classically ANCA negative. In negligible cases, there may be P ANCA positive, but we will consider a GPS as an ANCA negative. And normal ESR, normal CRP. This is the classical findings in case of GPS. And also listen to this very carefully. In case of GPA or vagus, patient will have ENT involvement like sinusitis, destruction of the nasal bridge, leading to either saddle nose or deafness. But when in the scenario they specifically mention regarding features of worsening asthma and features of RPGN, then you will think of the CSS or the EGP, eosinophilic granulomatosis with polyangiitis. So GP will have the classical ENT involvement like the sinusitis or epistaxis, destruction of the nasal bridge leading to saddle nose, or there may be deafness. And in case of CSS or EGPA, they will specifically mention worsening asthma, and they can also give you a clue that the patient is having features of eosinophilia. So what is the definitive management of GPS? Good posture syndrome. What is the
Plasma exchange.
Yes, plasma exchange is the definitive management. And a first line choice of treatment?
2C.
Corticosteroids
Yes.
and cyclophosphamide.
You should go for combination of 2C, corticosteroid plus cyclophosphamide. So let's consider the Granulomatosis with polyangiitis is an ANCA-associated vasculitis with pulmonary and the renal involvement. So there will be renal-pulmonary syndrome. The classical triad consists of necrotizing granulomatous inflammation of the respiratory tract, glomerulonephritis, and a small vessel vasculitis. And the ENT symptoms: deafness, sinusitis, destruction of the nasal bridge due to destructive granulomatous lesion are typical. GPA is almost always associated with the upper airway involvement, for example, nasal ulceration, crustic rhinorrhea, epistaxis. And most patients have evidence of granulomatous lung disease at presentation, which is often accompanied by an alveolar capillaritis. So GPA will have the predominant C ANCA positivity with anti-PR3, and MPO will have the predominantly P ANCA positivity and MPO. So P for P, G and C looks like similar, so G for C. And for the treatment, you need to go for a combination of 2C, cyclophosphamide plus methylprednisolone or corticosteroid followed by hemodialysis. And second one is our microscopic polyangiitis. MPA is most frequently associated with perinuclear anti-neutrophil cytoplasmic antibody, P-ANCA antibodies, and a raised MPO titer. MPA classically presents with worsening renal function, hemoptysis, purpuric rash affecting the lower limbs. And third one is our GPS and the good posture syndrome. So usually all the candidates knows GPA and GPS very well, but in part 2 exam they more frequently give MPA in the exam. So MPA will have P ANCA positivity, and there would be anti-PR3. GPS. Anti-GBM disease, also known as a good posture disease, classically presents with hematuria and rapidly progressive glomerulonephritis due to production of an antibody that targets the basement membrane of the kidneys. Small vessel vasculitis associated with both pulmonary hemorrhage, bilateral airspace opacification, rapidly RPGN, which is caused by anti-GBM antibodies against the type 4 collagen alpha 4. So So in case of anti-GBM disease, there would be linear IgG deposition along the basement membrane. And what should be the findings in case of GPA, the renal biopsy findings?
Crescentile.
Pochi-immune, there would be Pochi-immune crescentic chain. And in case of anti-GBM
Crescentic
antibody,
chain.
there would be linear IgG deposition along the basement membrane. So IgG deposition, which is linear, crescent formation, and the anti-GBM antibodies. And the initial choice would be combination of 2C, corticosteroid plus cyclophosphamide. Definitive is the plasmapheresis. And this type of patient may also comes up with the features of history of renal transplant failure. A Good-Pasha syndrome is an autoimmune pulmonary renal syndrome due to circulating antibody directing at the glomerular basement membrane. The most frequent class of antibody implicated in GPS is the IgG. The combination of hemoptysis with radiological findings consistent with pulmonary hemorrhage, meaning diffuse alveolar infiltration, red cell cast in the urine, points towards the diagnosis of GPS. Good-Pasha is usually present with a potentially life-threatening pulmonary hemorrhage, profound renal impairment, which requires plasmapheresis. In acute flares of Good-Pasha disease, plasmapheresis, meaning therapeutic plasma exchange, is the first line in order to try and removing circulating antiglomerular basement antibody disease. And in patient with GPS, the prognosis is drastically improved with the removal of antigen through plasmapheresis, immunosuppression with corticosteroid and cyclophosphamide. So regarding the crescentic gene, so crescentic gene, this is usually classified into 3 categories. Number 1 is the anti-GBM disease, which comes up with the features of Good-Pasha syndrome. Second one is the immune complex mediated glomerulonephritis, which is commonly found in case of lupus nephritis or IgA nephropathy. And third one is the Pochi-immune glomerulonephritis. This is commonly found in the ANCA-associated vasculitis like GPA, MP, and the EGP, also known as CSS. This is regarded as a Pochi-immune because it will lack the significant immune complex deposition on immunofluorescence. And for the definitive diagnosis of crescentic glomerulonephritis, you will be going for the renal biopsy. Renal biopsy will show the presence of crescent, and this crescent is usually formed by proliferation of the cells in the Bowman's capsule, which will affect more than 50% of the glomeruli. And if you go for the immunofluorescence, then in that case you can differentiate whether this is anti-GBM, which will comes up with linear staining, and in case of immune complex mediated, there would be granular staining, and in the post-immune like GP or MP, it would be negative. And regarding the management, so initially you should go for immunosuppressive therapy, combination of 2C, and in some cases you can also go for anti-CD20, meaning rituximab, and for the definitive you need to go for the plasmapheresis. And some of the patients even may require dialysis, and also you need to go for symptomatic management of hypertension, fluid balance, anemia, as well as the respiratory symptoms. So if we consider the other options, so IgA nephropathy. So IgA nephropathy, this type of patient will comes up with the features of isolated hematuria with the history of upper respiratory tract infection, usually following 1 to 2 days, and it will usually follow some more indolent course, and there won't be any this type of rapid deterioration in the renal function. Regarding the membranoproliferative glomerulonephritis, so in case of membranoproliferative glomerulonephritis, also known as the mesangiocapillary, there would be mesangial cell proliferation, and this type of patient will comes up with the nephrotic range proteinuria, usually protein 3+. There may be also features of hematuria, and this is also chronic. It does not comes up with the features of RPGN. Membranous nephropathy is the most common cause of nephrotic syndrome in the adult, and it will comes up with the significant proteinuria, and there should be features of nephrotic syndrome. But here we are getting combination of both hematuria and the proteinuria, and it is not fulfilling the nephrotic range proteinuria. And membranous nephropathy may be idiopathic. Membranous nephropathy may be the typical variant, and typical variant, this is usually related to cancer or some other condition, especially the infective condition. So which type of infection are related to membranous nephropathy?
Hepatitis B.
Other than hepatitis B?
Malignancy.
Malaria, syphilis.
So most common one is the malignancy. In most of the cases, this is related to malignancy, and nephrotic syndrome is the main presentation. And regarding the infective cause, the most common is the hepatitis B. It can also be related to hepatitis C, syphilis, malaria, but the most important one is the hepatitis B. So so in case of idiopathic membranous GN, which type of appearance should be found in case of electron microscopy? Spike and
Dome.
yes,
Spike
it will
and
have the
dome.
spike and dome appearance. And which one will have the tram track appearance?
Tram track membranoproliferative.
Membranoproliferative, especially the type 1, it will have the tram track appearance involving the subendothelial electron dense deposit. And in case of idiopathic membranous GN, there would be subepithelial electron dense deposit leading to the spike and dome appearance. So how to treat a case of membranous glomerulonephritis? Stepwise management. What should be the first line choice of drug for the management of hypertension?
AC inhibitor.
Yes, you should be going for either AC inhibitor or angiotensin receptor blocker. And what should be the second line choice, or what should be the next step in the typical variant?
Steroids.
You should go for combination of 2C. So AC inhibitor or angiotensin receptor blockers followed by combination of 2C. Corticosteroid plus cyclophosphamide. This is the choice of treatment in case of typical membranous nephropathy, which is related to the either malignancy or infective process or some other condition. And in case of idiopathic membranous GN, the first line would be same, AC inhibitor or ARBs. The second line would be anti-CD20 followed by cyclosporin. If there is no response, go for combination of 2C. So in the typical variant, 2C, and in the idiopathic variant, 4C. CD20, cyclosporin, and combination of 2C. Next one is our amyloidosis. So amyloidosis will comes up with nephrotic syndrome or nephritic syndrome.
Nephrotic syndrome.
Yes, amyloidosis will comes up with the nephrotic syndrome. So patient will have nephrotic range proteinuria, and the patient will also have the more chronic symptom rather than the acute decline in the renal function. And whenever in the scenario you find the combination of glomerulonephritis plus features of AKI, always think of the RPGN, which is commonly related to GPA, MP, and GPS. So this is our crescentic glomerulonephritis. This elderly woman's serum creatinine has risen from normal to 252 micromole per liter in less than 6 months. This feature, along with tiredness, arthralgia, urine analysis that shows a moderate amount of protein and blood, a mild anemia makes it likely that she has an ANCA-associated vasculitis. A crescentic glomerulonephritis is a typical renal histological findings in the circumstances. The other options are all much less likely to cause rapid development of renal failure. In addition, renal amyloidosis, membranous nephropathy usually presents with nephrotic syndrome.
What is the most appropriate treatment? Aminophylline, CPAP, doxapram, furosemide, NIV. An 87-year-old man presented to the ED with a 4-week history of breathlessness, dry cough, and confusion. He also complained of headaches that were worse in the morning. He had a history of TB as a teenager. On examination, he was drowsy. GCS was 14. His pulse was 102 beats per minute, and respiratory rate was 24 breaths per minute. His oxygen saturation was 85%, breathing air. On auscultation of his chest, there were some crackles in the left lower zone and generally decreased breath sounds on the right. On ABG, breathing air, PO2 6.8, PCO2 9.8, pH 7.25, H plus 56, bicarbs 32, base excess was plus 10. Chest X-ray shown below. What is the most appropriate treatment?
So this patient has a 4 weeks history of breathlessness, dry cough, confusion, and as well as the morning headache, so which can be associated with the chronic respiratory issues with acute exacerbation. And if we analyze the ABZ, so patient is having the low partial pressures of oxygen, there is hypoxia, and the PCO2 is normal. So is it type 1 or type 2 respiratory failure?
2. Type 2.
This is PCO2 is 9.8, which is high.
Yes, sorry, PCO2 is high. So this is our type 2
Type 2.
respiratory failure. In case of type 1 respiratory failure, there would be only isolated hypoxia. And in case of type 2, there should be combination of both hypoxia as well as hypercapnia. And the patient pH is significantly low, including acidosis. H plus is also high, reflecting acidosis. The bicarbonate level is elevated, indicating the compensatory metabolic alkalosis in response to the respiratory acidosis. And there is also base excess plus 10, which is also indicating the compensatory metabolic alkalosis. So these findings, they are consistent with the acute and chronic respiratory acidosis due to the carbon dioxide retention. And if we analyze the physical examination, so patient is having the features of drowsiness. So drowsiness usually indicates the potential hypoxemia and the hypercapnia, which usually affects the central nervous system. Patient is also having the features of breathlessness, confusion, as well as the headache, and there is also prior history of tuberculosis. So all of them are consistent with the acute respiratory failure. The confusion can be explained by the carbon dioxide retention causing the altered mental status. The oxygen saturation is also low, indicating there is significant hypoxemia. The respiratory rate is also increased, 24 beats per minute. And on chest examination, there is crackles on the left lower zone and decreased breath sound on the right. So it can be explained by either pneumonia or the pleural effusion. And if we go for our X-ray findings, so patient is having the crackles in the left lower zone, and also there is some portion of patchy consolidation in the left lower lobe, indicating patient is having the left lower lobe predominant pneumonia. And on the right side, there is features of pneumonectomy as well as the thoracoplasty. So the decreased breath sound in the right, it can also be explained by the right-sided thoracoplasty with the pneumonectomy. So based on the clinical presentation and the ABZ findings, this indicates the acute on chronic type 2 respiratory failure, which has likely exacerbated by development of our left lower lobe pneumonia. So what should be the most appropriate treatment?
CPAP.
Non-invasive ventilation.
So this non-invasive ventilation, it will be the most appropriate treatment for this patient, given there is evidence of significant hypoventilation, hypoxia. Patient is having features of both hypoxia and hypercapnia, and patient will be ultimately needing for the ventilation support. And this NIV, non-invasive ventilation, it will address both hypoxemia as well as the hypercapnia by increasing the gaseous exchange, and it will also support the respiratory function by assisting with both oxygenation and the carbon dioxide removal. So this non-invasive ventilation, this is usually effective in the management of acute respiratory failure in by two way. It will causes assistance with the ventilation, and it will also causes prevention of further intubation. So this NIV, it will provide the positive pressure ventilation, which will help us to reduce both hypercapnia and improve the oxygenation. This NIV, it will increase the tidal volume, and it will also improve the alveolar ventilation, and which will ultimately remove the carbon dioxide from the bloodstream, and it will also enhance the ventilation perfusion ratio, which can improve the oxygenation and correct the hypoxemia. And this NIV, it will also help us to avoid the need for the invasive mechanical ventilation. So this non-invasive ventilation, it will reduce both hypercapnia, and it will also improve the oxygenation. And regarding the setting and adjustment, so usually either we can go for the BiPAP, bi-level positive airway pressure. For this procedure, we need to going for the different pressure for the IPAP and the EPAP, which will help both for ventilation and oxygenation. And another setting is the CPAP with the backup support. And in case of CPAP with the backup support, it will only enhance the oxygenation. It will not help to reduce the hypercapnia, meaning it will not help us to reduce the elevated partial pressures of carbon dioxide. So non-invasive ventilation with the BiPAP, bi-level positive airway pressure, it would be most appropriate here. And regarding other options, so aminophylline, this is a bronchodilator used in a patient with COPD or asthma, and this is not typically the first line treatment in case of acute respiratory failure or with significant hypoventilation with hypercapnia. The CPAP, this is primarily used to treat the sleep apnea, and can also be helpful in some of the condition like the congestive cardiac failure or pulmonary edema. And the patient is having significant, just address the oxygen, it does not assist with removal of the carbon dioxide. So since this is also only helping with the oxygenation by increasing airway pressure, but it will not assist us with the removal of carbon dioxide, so it would be less appropriate. Doxapram, this is the respiratory stimulant used to stimulate the breathing in patient with hypoventilation. This doxapram can be used in certain situation, but non-invasive ventilation, this is usually preferred in more severe respiratory failure, since this is more effective ventilatory support. And doxapram also leads to life-threatening arrhythmia. Furosemide, this is the diuretic used to manage the fluid overload as well as the pulmonary edema, and in this scenario there is no clear indication of fluid overload or edema, so we should be going for the non-invasive ventilation. So regarding base excess, what is the normal interval of base excess, and what is the importance of positive value, and what is the importance of negative value?
Plus minus 2, I think.
Yeah,
minus
plus minus 2 is the normal range. So this base excess, this is the amount of excess or insufficient level of bicarbonate in the blood. So it reflects the amount of strong acid or base that would need to be added or removed from the blood to return the pH to the normal value, meaning the central 7.4 when the blood is at the standard partial pressures, when the blood is in its standard PCO2 level. So usually the normal range is usually from -2 to +2 milliequivalent per liter. And in the base excess, it can be either positive or it can be negative. So it will help us to detect whether this is metabolic acidosis or this is metabolic alkalosis. A negative base excess indicates that there is a deficient of bicarbonate, and this is suggestive of metabolic acidosis. And a positive base excess indicate that there is an excess of base, so it will be suggestive of the metabolic alkalosis. So we are having excessive here, +10, so this is suggesting the metabolic alkalosis. And since this patient is having respiratory acidosis, so it is rising as a compensatory mechanism. This man developed acute on chronic type 2 respiratory failure. She has previously undergone a right-sided thoracoplasty as treatment for tuberculosis, an operation which was commonly performed in 1940s and the early 50s before the advent of combination anti-tuberculous chemotherapy. It is likely that he has decompensated because of developing the left lower lobe pneumonia. The preferred initial form of treatment and correct answer for his respiratory failure is the non-invasive ventilation to provide assisted ventilatory support. This is preferable to CPAP in the context of an raised PCO2. Doxapram is less effective and more toxic than NIV due to the risk of arrhythmia. There is no suggestion of bronchospasm or cardiac failure. That aminophylline and furosemide are not indicated.
What is the most likely diagnosis? Antiphospholipid antibody syndrome, cryoglobulinemia, mixed connective tissue disease, systemic lupus erythematosus, and TTP. 34-year-old woman was admitted with shortness of breath and found to have a pulmonary embolus. On systematic inquiry, she admitted to cold intolerance. She was not taking any medication. On examination, she has a livedo reticularis rash on her thighs. Hemoglobin 126, WBC 4.2, lymphocyte count 1, ANA was negative, lupus anticoagulant positive, serum complement C3 120, serum complement C4 45. What is the most likely diagnosis?
So the clinical presentation of this patient with a history of pulmonary embolism, livedo reticularis, positive lupus anticoagulant, and the normal complement level. So this is most consistent with the antiphospholipid antibody syndrome, and this is APS is the most likely diagnosis here. And patient will ultimately require long-term anticoagulation therapy to further prevent the thrombotic events. So if we analyze the key points to support the diagnosis, so this patient is having the history of pulmonary embolus. So this APS, this is a prothrombotic disorder that increases the risk of venous and arterial thromboembolism, including pulmonary embolism. And the presence of pulmonary embolus in a relatively young woman, otherwise healthy individual, raises the suspicion of an underlying hypercoagulable state like the antiphospholipid antibody syndrome. The cold intolerance, this is more commonly associated with thyroid dysfunction, but it can also occur in association with other autoimmune disorder like the Raynaud's phenomenon. Cold intolerance, this is not the primary symptoms of antiphospholipid antibody syndrome, but APS, this is often associated with the Raynaud's phenomenon. And livedo reticularis, this is the classic skin manifestation of antiphospholipid antibody syndrome. So it usually presents as a net-like mottled purplish discoloration of the skin, and this is more commonly visible either in the thigh or in the lower extremities. And this livedo reticularis, this is usually caused by occlusion of small blood vessel within the skin. And if we go for the laboratory findings, so patient is having the positive lupus anticoagulants, and this positive lupus anticoagulant, this is the hallmark of antiphospholipid antibody syndrome. So although the name is the anticoagulant, despite its name, the lupus anticoagulant, it will increases the risk of clotting. It will not increases the risk of bleeding. It usually interferes with the phospholipid dependent coagulation test, which will ultimately prolongs the clotting time, and it will promote the thrombosis, which is a paradoxical explanation. And patient with normal patient in case of ASLE, patient will have the low complement level, especially during the active disease due to the immune complex formation. And in contrast, in case of APS, patient will have the normal complement level, and this is also help us to differentiate between antiphospholipid antibody syndrome and the SLE. And the absence of anti-nuclear antibody, this is and the absence of other autoimmune marker, this is also making the SLE and the MCTD, mixed connective tissue disorder, unlikely. So what are the diagnostic criteria of antiphospholipid antibody syndrome? Diagnostic criteria, anyone?
Anticardiolipin antibodies and lupus antibody.
Positivity.
More than 3 miscarriage and
Yeah,
positive.
and
respiratory
history.
lupus.
History also.
Storage, pain,
Miscarriage or thrombotic manifestations, symptoms.
A combination of thrombophilia, recurrent miscarriage, thrombocytopenia, leukopenia is associated with SLE, such type of diagnosis of antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome is a common cause of acute thrombophilia characterized by arterial or venous thrombosis and pregnancy mortality association with the circulating antiphospholipid antibodies. There are heterogeneous groups of approximately 20 autoantibodies directed against phospholipid binding plasma proteins. Three of the most clinical importance are the lupus anticoagulant, anti-beta-2 glycoprotein 1 antibodies, and the anti-cardiolipin antibodies. They can be detected either by phospholipid dependent coagulation test for lupus anticoagulant or ELISA test for anticoagulation and anti-beta-2 GPI antibodies. Antibodies should be demonstrated at least 2 occasions separated by 12 weeks. And APS, it may be primary or it may be associated with other condition like with the SLE. So patient with SLE are at a risk of developing antiphospholipid antibody syndrome. So regarding the diagnostic criteria, so APS is present if the patient has anti-cardiolipin antibody or lupus anticoagulant on 2 occasions for a period of 12 weeks and either has thrombus or a history of recurrent miscarriage before 10 weeks of pregnancy, or there is a single pregnancy loss after 10 weeks of gestation when other causes of pregnancy loss has been excluded. The occurrence of even a single thrombotic event in patient with APS warrants lifelong anticoagulation with warfarin, as the risk of recurrence is 20 to 70%. Low molecular weight heparin should be used initially while loading warfarin. And based on the new evidence, they are also suggesting that you can also go for the directly oral acting anticoagulant as well. Antiphospholipid antibody syndrome is the most treatable cause of recurrent miscarriage, defined as loss of 3 or more consecutive pregnancies. Aspirin and low-dose heparin is the treatment of choice to reduce the risk of miscarriage in confirmed APS. Antiphospholipid antibody syndrome, which is a non-inflammatory prothrombotic state in vivo, the presence of laboratory tests suggesting an anticoagulant state. And the antiphospholipid antibodies causes coagulation defect in vitro, raised APTT, which fails to correct after addition of the normal human plasma. So in simple term, the APTT won't normalize after addition of the normal plasma. So regarding the other differential, the cryoglobulinemia, this is associated with the immune complex mediated vasculitis, and this type of patient usually comes up with the palpable purpura, arthritis, and features of glomerulonephritis. And in case of cryoglobulinemia, patient will have the reduction in the complement, a significant reduction of both C3 and the C4, and this is also usually related to hepatitis C infection. And it can cause the cold induced symptoms like the cold intolerance, but this is not associated with pulmonary embolism or levodoreticularis or positive lupus anticoagulant. The MCTD, so MCTD, they comes up with the features of SLE, systemic sclerosis, and polymyositis, and they are typically associated with anti-U1 RNP. And the absence of these antibodies and also the negative ANA, it makes the MCTD less likely. The ACL is a multi-system autoimmune disorder, and this is often associated with positive ANA and T double-stranded DNA and the low complement level, especially during the period of flare or during the active phase. And the negative ANA and the normal complement level, it also making SLE less likely. So thrombotic thrombocytopenic purpura, so it will comes up with the triad. So what are the triad of TTP? Sorry, not the triad, it will comes up with the pentad. ITP will comes up with the triad, TTP will comes up with the pentad. So so what will be the triad of HUS? Sorry, not ITP, HUS, triad of HUS.
Microangiopathic hemolytic anemia, renal impairment, thrombocytopenia, fever, neurological features.
So in case of HUS, you will get the triad of acute renal failure, microangiopathic hemolytic anemia, thrombocytopenia. And in case of HUS, we will be getting the pentad, and the pentad will have the additional neurological features. The pentad will have additional fever and the neurological symptoms, and the presence of neurological features, it will differentiate from TTP. Neurological feature is the cardinal features of TTP, which is often absent in case of HUS. So what should be the first line choice of treatment for TTP? First line choice for TTP. How to treat a case of TTP?
One milligram response.
Choice of treatment, anyone? TTP?
Plasma exchange.
Yes, this is the plasma exchange. Plasma exchange is the first line choice of treatment. And for the refractory case, you'll be going for the IV immunoglobulin. First line is the plasma exchange. Plasma exchange removes any antibodies that inhibits the ADAMTS13 whilst also replacing the functioning version of the enzyme. So first line would be plasma exchange, and for refractory cases you will be going for the IV immunoglobulin. And how to treat a case of HUS? Supportive management, and you can also go for a trial of eculizumab. So TTP, plasma exchange, HUS, supportive management. So this is our antiphospholipid antibody syndrome. The event of a pulmonary embolism in a 34-year-old woman who also has levator reticularis, a prolonged APTT time suggests either primary antiphospholipid syndrome or ACLE with secondary antiphospholipid antibody syndrome. The cold intolerance alludes to Raynaud's phenomenon. The lymphopenia is more of a feature of ASLE than primary antiphospholipid antibody syndrome. However, as the anti-nuclear antibodies are negative, there is no evidence of complement activation, so ASLE is ruled out. There is nothing in the history to suggest cryoglobulinemia, MCTD, or TTP. Okay, next.
What is the most likely diagnosis? Atopic eczema, dermatitis artifacta, guttate psoriasis, lichen planus, pityriasis versicolor. 19-year-old woman presented with a widespread skin eruption 2 weeks after having had a sore throat. On examination, she had multiple 5 mm diameter scaly erythematous papules over her trunk and limbs. What is the most likely diagnosis?
So most likely diagnosis. So the most likely diagnosis for this 19-year-old woman with a widespread skin eruption, erythematous scaly papule distributed across the trunk and lip, appearing 2 weeks after the sore throat. So most likely this is the gutted psoriasis. So what are the key points supporting the diagnosis? So number one, there is a history of the sore throat. So this gutted psoriasis, this often follows the streptococcal infection, particularly streptococcal pharyngitis, which comes up with the features of sore throat. And this condition usually develops after within 1 to 3 weeks. And this patient has comes after 1 week. And the body's immune response, to the infection, they usually trigger an inflammatory response in the skin, and this leads to the characteristic lesion known as the gutted psoriasis. And regarding the clinical presentation, so the gutted psoriasis usually comes up with a multiple small, and there will be scaly erythematous papule distributed over the trunk and the limb. This is the classical appearance of the gutted psoriasis, and the lesions are typically very small, usually ranging from 1 to 10 millimeter in diameter. They are usually either red color or pink color, which is supporting the erythematous papule, and they are also covered by the fine scale. And the word the gutted means the drop, since they will have the teardrop appearance following the sore throat. This is the cardinal features of gutted psoriasis. And regarding the age group, gutted psoriasis, it usually affects the children and the young adult. So here we are having the 19-year-old woman. So and often this presents in, for the first time during the adolescence or the early childhood. So patient will comes up with the teardrop scaly papule following the sore throat. So teardrop scaly papule, acute onset of teardrop scaly papule on trunk and limbs is highly suggestive of the gutted psoriasis, classically preceded by streptococcal sore throat 2 to 4 weeks prior to appearance of the skin lesion. Gutted psoriasis is most common in children and young adult and often follows an upper respiratory tract infection with Streptococcus species. So choice of treatment for gutted psoriasis, first line, topical
Spontaneously
steroid
healing.
or topical vitamin D analog. In case of gutted psoriasis and in case of flexural psoriasis, first line would be topical steroid. And in case of extensor psoriasis or other forms of psoriasis except flexural and gutted, you will be going for topical vitamin D analog with or without topical steroid. So if we go for the other diagnosis, so atopic eczema. In case of atopic eczema, there should be history of atopy, and patient usually comes up with the itchy, inflamed skin, commonly affecting the flexural surface of the body, commonly affecting inside of the elbow or behind the knee. And this type of lesion, they are usually more diffuse and they are less likely to present with well demarcated scaly papule here. Dermatitis artifacta. This is an psychiatric associated condition where the skin lesions are self-inflicted. In this case, the patient will deliberately harm their skin with the pattern of lesion, often producing an unusual, bizarre, either linear or geometric pattern. Lichen planus. Lichen planus, they will come up with the features of P. So P for planus, pruritic, polygonal, purple colored, flat top papules. So they will be characterized by pruritic, polygonal, purple, flat top papules. And they are also usually found in the wrist, lower legs, and also there would be the classical mucous membrane involvement known as the Wickham striae. So how to treat lichen planus? Treatment of lichen planus.
Steroid.
Topical or oral
Steroid.
steroid?
Topical steroid.
Yes, we'll be going for the topical steroid. And this Wickham striae is the pathognomonic feature. There would be whiteless pattern on the buccal mucosa. Potent topical steroid are the mainstay of treatment for lichen planus. Infection with hepatitis C is the risk factor for developing lichen planus. Nail involvement can be seen in lichen planus and is characterized by longitudinal grooving or raising, which can be helpful at differentiating the condition from psoriasis. Pityriasis versicolor. So versicolor means varieties of color like hypopigmented, hyperpigmented, or erythematous macule. So this is the fungal infection which usually presents at either hypopigmented, hyperpigmented, or erythematous macule with fine scaling, typically affecting the trunk. And the lesions are usually more subtle and they usually don't exhibit erythematous or distinct scaly nature that are seen in the gutted psoriasis. So we'll be going for the gutted psoriasis. So following sore throat, teared up scaly papules, gutted psoriasis, unless proven otherwise. This young woman has developed an exanthem shortly after a sore throat. The description of the rash, in particular, the size of the lesion, scaling, and widespread distribution with relative sparing of the face, is typical of gutted psoriasis. The main differential diagnosis to consider in this setting are the pityriasis rosea, which is also common in this age and follows a sore throat, secondary syphilis, but this option are not given. The other disease given do not typically follow a sore throat unless coincidentally. Atopic eczema does not generally produce scaly papule. The papule in lichen planus are classically flat-topped, not scaly. Pityriasis versicolor presents with scaling and pigment change rather than papule. Dermatitis artifacta can present in many different ways but not as a widespread scaly rash and should only be considered when other pathologies have been excluded.
What is the most likely diagnosis? Cryptosporiosis, flare-up of diverticular disease, ischemic colitis, pseudomembranous colitis, and tumor progression. 60-year-old man was admitted with a 3-day history of diarrhea. A diagnosis of lung and peritoneal mets from an unknown primary carcinoma had been made for 4 months previously, and he had been receiving platinum-based combination chemotherapy. He had been discharged from hospital 5 days previously after an episode of neutropenic sepsis following his second cycle of chemotherapy. On examination, he was apyrexial. His pulse was 98 beats per minute and BP was 110/65 millimeters of mercury lying. He looked dehydrated. His abdomen was soft but tender over the left iliac fossa. Hemoglobin 113, WBC was 6.5, neutrophil count 5.4, platelets 170, and CT scan of abdomen showed thickened sigmoid colon. What is the most likely diagnosis?
So the most likely diagnosis for this 60-year-old man with a 3 days history of diarrhea, a recent history of neutropenic sepsis following chemotherapy, and a CT scan showing a thickened sigmoid colon. This is highly suggestive of the pseudomembranous colitis, also known as the Clostridium difficile diarrhea. And pseudomembranous colitis should be treated promptly because they are often associated with the severe complication like the toxic megacolon or perforation as well. So what are the key points in favor of the diagnosis? So number one, there is a recent recent chemotherapy and hospitalization. So this patient has a history of the metastatic cancer and has been undergoing the platinum based chemotherapy regimen. So patient who are undergoing chemotherapy, they are often at a higher risk of neutropenia, and which will lead to the infection acquiring hospitalization, and often the patient will be needing for the broad spectrum antibiotic. So this patient had the neutropenic sepsis, and the antibiotics were most likely administered. So which antibiotic is used in case of neutropenic sepsis? First line. In case of neutropenic sepsis, which antibiotic is most commonly used?
Piperacillin tazobactam.
Yes,
Piperacillin tazobactam.
combination of piperacillin and the tazobactam. And if the patient has history of penicillin allergy, then what should be the alternative regimen? In neutropenic sepsis, alternative regimen?
Clindamycin.
Yes.
Clindamycin.
No, not clindamycin. We need to go for the
Cyprofen.
Cipro and vancomycin. Okay, and I need to correct this. So currently they have omitted the gentamicin. No need to go for gentamicin in a patient with neutropenic sepsis. So first line would be piperacillin tazobactam if the patient is penicillin sensitive, and if the patient is penicillin allergic, then go for the Cipro and vancomycin, ciprofloxacin and vancomycin. So either you go for tazocin or you go for the Cipro and vanco. So all of them are the broad spectrum antibiotics, and the broad spectrum antibiotics, they usually disrupt the normal bacterial flora of the intestine, leading to overgrowth of Clostridium difficile. And this type of bacteria, they causes inflammation of the colon and they will release the toxin, and patient will ultimately comes up with the features of pseudomembranous colitis. So the diarrhea is the hallmark of pseudomembranous colitis, and this is always occurs following the antibiotic use, especially the broad spectrum antibiotics. And this type of diarrhea, this is usually watery and can be associated with some sort of abdominal pain and tenderness, especially in the left lower quadrant or in the left iliac fossa. And the presence of light iliac fossa tenderness, it also suggests that the inflammation is localized to the colon, which is consistent with the colitis. And if you go for the CT scan of abdomen findings, there is thickening of the sigmoid colon. So this finding is also typical for the pseudomembranous colitis. There would be colonic wall inflammation and thickened due to formation of the pseudomembrane. And this pseudomembrane, they are usually composed of the inflammatory, either inflammatory cell or some sort of the necrotic debris, and which can they can also be visualized through the colonoscopy as well. So how to treat a case of life-threatening Clostridium difficile diarrhea?
Oral Venco IV Metro.
Yes, we should go for the OV,
Oh,
oral
yeah.
vancomycin and IV metronidazole. So if we analyze the other differentials, so cryptosporidiosis. So this is the most common cause of infective diarrhea in the immunocompromised patient. And this is one of the protozoal diarrhea, commonly causes the chronic and profuse diarrhea in the immunocompromised individual or those patients who are taking the immunosuppressive therapy following the post-transplantation. And this is also detected by using the modified acid for staining. And this cryptosporidiosis, it will not result in the colonic wall thickening, that is seen in the CT scan. And regarding the patient clinical context, the recent antibiotic use, and the patient is just in the second cycle of chemotherapy, so this is less likely to be the immunosuppressed patient. So this is making the cryptosporidiosis less likely. Flare up of diverticular disease. So diverticular disease can also cause the left-sided abdominal pain and tenderness. And the recent history of chemotherapy, neutropenic sepsis, and the antibiotic use, this makes the pseudomembranous colitis more likely. Ischemic colitis, they will come up with the features of severe abdominal pain and bloody diarrhea following ischemic event. And if you go for the imaging, then there would be the thumb printing pattern due to the submucosal hemorrhage or edema, not thickened sigmoid colon. Tumor progression can cause abdominal symptoms, but they will not come up with this type of CT findings. They are not also related to recent antibiotic use. So this is our pseudomembranous colitis. The patient has recently received potent broad-spectrum antibiotics in a hospital setting. These risk factors, the CT findings, and the timescale support a possible diagnosis of hospital-acquired infection, Clostridium difficile, the causative organism of pseudomembranous colitis. Cryptosporidiosis would be an important differential diagnosis in chronic immunosuppressed state such as HIV infection, but is unlikely after just 2 weeks of solid tumor chemotherapy. Acute diarrhea would be very unusual symptom of progressive solid malignancy, even in patient with peritoneal disease. There are no additional features in the stem to suggest diverticular disease or an ischemic colitis in this patient.
What is the most likely diagnosis? Active multiple myeloma, amyloidosis, low-grade lymphoma, MGUS, solitary plasmacytoma. 79-year-old woman was referred to the medical outpatient clinic with a 3-month history of lower back pain. She was taking regular paracetamol and occasional ibuprofen. She was normally fit and active with no other complaints. Examination was normal. In investigations, FBC was normal, serum urea and electrolytes were normal, calcium was normal. IgG 15.2, IgA 2.5, IgM1, serum protein electrophoresis showed IgG kappa paraprotein 4.3, serum free light chain ratio 1.30, X-ray of lumbar spine showed generalized osteopenia, no focal collapse, mild degenerative changes. What is the most likely diagnosis?
This 79-year-old woman presenting with 3 months history of lower back pain is referred for evaluation, and she has a normal physical examination and normal basic laboratory findings except for serum immunoglobulin and the serum protein electrophoresis, and mild changes in the X-ray of the lumbar spine. So if we go for the key findings, so patient is having elevated serum IgG level, the serum protein electrophoresis, IgG kappa paraprotein level, this is mildly increased. So the normal level should be less than 3 gram. The typical range for normal paraprotein level or monoclonal protein, this is considered to be less than 3. In this case, there is mildly elevated. Serum free light chain ratio is within the normal range. X-ray of the lumbar spine is showing the generalized osteopenia without focal collapse, and mild degenerative changes. And there is also no significant features of CRAB, meaning there is no features of anemia, hypercalcemia, or renal dysfunction, which are more commonly associated with the multiple myeloma. So most likely diagnosis So the most likely diagnosis is the MGUS, monoclonal gammopathy of undetermined significance. So this is characterized by the presence of monoclonal paraprotein band with slight elevation greater than 3 gram per liter, but it will always be less than 30 gram. And there would be no evidence of hematological, there will be no other evidence of hematological disorder, there would be no evidence of end organ damage, and usually the physical presentation will be usually normal. So the paraprotein level, regarding the paraprotein level, in case of MGUS, the IgG level will also be less than 30 gram, and the IgG paraprotein band will also be less than 30 gram per liter, but there will be mild elevation. And in case of multiple myeloma, usually this level would be more aggressive, greater than 30 gram per liter. And the second criteria is that there would be lack of symptoms. The MGUS typically does not cause the symptoms, and there should not be any significant organ damage. So this patient normal physical examination and as well as the absence of end organ damage, this is also making MGUS more likely. And there is no features of CREB, there is no features of hypercalcemia, renal failure, anemia, or significant bone lesion. There is just generalized osteopenia. And in case of MGUS, patient will have the normal serum free light chain ratio. Light chain ratio should be normal in case of MGUS. And this MGUS, this is also more common in the older patient, and this usually remains stable without progressing to the multiple myeloma. So what are the diagnostic criteria for MGUS? Can anyone recall? There are 4 points, the diagnostic criteria for MGUS. So a monoclonal paraprotein band less than 30 gram per liter. So normal value is less than 3. It should be greater than 3 gram, but this is always less than 30 gram. And in case of multiple myeloma, the level should be greater than 30 gram per liter. And in case of WM, Waldenström macroglobulinemia, the IgM level. In case of MGUS, IgG level, this is greater than 3. And in case of Waldenström macroglobulinemia, IgM level should be greater than 30 gram. Plasma cell less than 10% on bone marrow examination. No evidence of bone lesion, anemia, hypercalcemia, renal insufficiency related paraprotein, meaning there should be no features of CREB. And this point is differentiating it from the multiple myeloma. There should be no evidence of another B cell proliferative disorder. So now if we consider active multiple myeloma, so in case of active multiple myeloma, there should be evidence of significant end organ damage, and they will typically comes up with the features of CREB, hypercalcemia, renal insufficiency, anemia, and osteolytic bone lesions. And the absence of these features and the normal light chain ratio, it also makes the multiple myeloma less likely. And also if we consider the bony lesion, in case of multiple myeloma, there should be osteolytic lesion, but here we are getting just the generalized osteopenia and mild degenerative changes, no features of lytic bone lesion. Amyloidosis usually involves deposition of amyloid protein in various organs, potentially affecting the kidney and the heart. And this patient does not exhibit any signs of organ involvement or symptom consistent with amyloidosis. Low-grade lymphoma. So low-grade lymphoma can also cause the paraproteinemia, but the low-grade lymphoma usually comes up with the more severe systemic symptoms, and there would be palpable lymphadenopathy, or there should be features of splenomegaly, and the physical examination is normal here. Solitary plasmacytoma, this typically presents with a single lytic bone lesion, or there may be localized mass of plasma cell, usually detect on the plain X-ray skeleton, or in case of MR scan of the thoracolumbar spine. And solitary plasmacytoma, it will also comes up with a very higher paraprotein level, usually close to 30 gram per liter. So if we further analyze regarding the IgG kappa paraprotein level, so the typical range, the normal range, typical range for paraprotein monoclonal antibody, this is usually considered to be less than 3 gram per liter. And in this scenario, we are getting greater than, we are getting 4.3, which is above the normal threshold level. And in case of MGUS, usually there should be elevated monoclonal protein, but this is always less than 30 gram per liter, and there will be absence of other symptoms. There should be no features of end organ damage. And in case of active multiple myeloma, IgG kappa paraprotein band will always be greater than 30. And also in case of solitary plasmacytoma, it will also be close to 30. So this is our MGUS, and in most of the cases, MGUS don't need to be treated. This individual has a low level IgG kappa paraprotein with no evidence of end organ damage, like patient is having normal hemoglobin, serum calcium, serum creatinine, plain X-ray of skeleton, or immune paresis. Her serum free light chain ratio is normal. This is entirely in keeping with an IgG monoclonal gammopathy of undetermined significance. AL amyloidosis is most commonly associated with renal or cardiac impairment, of which she has no evidence. A low-grade lymphoma is most likely to present with palpable lymphadenopathy or splenomegaly. The examination is normal here. Active multiple myeloma is defined as myeloma with evidence of organ or tissue involvement, such as bone disease, meaning lytic lesion, vertebral collapse or fracture, hypercalcemia, bone marrow failure with anemia or kidney failure. It is an indication for systemic anti-myeloma treatment. Patient does not have any features to suggest symptomatic myeloma. A plasmacytoma by definition is a solitary lump of plasma cells, usually detected on plain X-ray of skeleton or MR scan of the thoracolumbar spine. There is nothing to suggest this here.
What is the most appropriate next management step? Antipyretic, IV acyclovir, intravenous flucloxacillin, oral val acyclovir, varicella zoster hyperimmune globulin. 24-year-old man presented with a 2-day history of fever and a generalized blistering rash. He had been taking prednisolone 20 mg daily for more than 2 weeks because of severe asthma. His son had chicken pox 2 weeks previously. On examination, he was low in mood. His temperature was 38.5 degrees Celsius. BP was 118/76 millimeters mercury, and his respiratory rate was 14 breaths per minute. Oxygen saturation was 96%, breathing air. He had a widespread eruption consisting of vesicles and pustules. Examination of his chest showed a few wheezes but no crackles. On investigations, hemoglobin 128, WBC 15.2, neutrophil count 13.8, lymphocyte count 1, platelet count 189. Chest X-ray was normal. What is the most appropriate next management step?
The clinical scenario describes as the 24-year-old man presented with 2 days history of fever and widespread blistering rash with vesicles and pustules, has developed most probably the disseminated varicella zoster infection, commonly known as chickenpox, likely due to exposure from his son. And given the history of prolonged steroid use for severe asthma, his immune system is compromised, so placing him at a higher risk of severe and disseminated VZV infection. So 20 milligram prednisolone 20 milligram daily for more than 2 weeks. So does it fall under immunocompromised state? Yes or no?
Yes, sir. More than 2 weeks.
So any
Yes.
patient who is taking prednisolone 40 milligram or more for longer than 7 days, or who is taking prednisolone 20 milligram or more for longer than 14 days is classed as immunocompromised. 40 milligram greater than 1 week, 20 milligram greater than 2 weeks. So this falls under the immunocompromised state. So this immunocompromised state, it usually increases the susceptibility to infection, including the viral infection, VZV. And also patient on long-term steroid, they are also at increased risk of severe manifestation of the infection that would typically be mild in immunocompetent individuals. So if we analyze the clinical presentations, the patient that has comes up with the features of fever, generalized rash, and the vesicles and pustules, they are characteristics of the VZV infection. In an immunocompromised patient, this can progress to the disseminated form involving the multiple organ system as well. And the presence of widespread eruption of vesicles and pustules rather than being confined to the specific dermatome. This indicates the more severely and potentially disseminated infection, which is commonly found in immunocompromised patient. And there is also a relevant exposure history. The patient recent contact with his son who had chickenpox is most likely the source of infection, and history of chickenpox 2 years prior is also the typical incubation period for the VZV. And regarding investigation, the white cell count is elevated, so leukocytosis with neutrophilia, this suggests an ongoing systemic inflammatory response. There is lymphopenia, this is consistent with immunosuppression, possibly due to the steroid use. And the chest x-ray is normal, so this normal chest x-ray, this is significant because this is ruling out the complication of VZV pneumonia, but it does not exclude the need for the aggressive treatment. So considering the immunosuppressed state and the clinical presentation suggestive of disseminated VZV infection, which one would be the most appropriate next management step?
IV acyclovir.
Yes, we will be going for the IV acyclovir. It would be the most appropriate and urgent treatment to control the infection and also to prevent the life-threatening complications. So this IV acyclovir, this is the treatment of choice for severe or disseminated VZV infection, especially in the immunocompromised patient. So what is the mode of action of acyclovir? This is the DNA polymerase inhibitor. Acyclovir is DNA polymerase inhibitor. It works by inhibiting the viral DNA synthesis, which is crucial for controlling the spread of the virus. And regarding the severity of the infection and as well as the prevention of complication, the IV acyclovir would be the most appropriate. And regarding other options, antipyretic, so this is suitable just for the symptomatic management of fever. It will not address the underlying viral infection. IV flucloxacillin, this is an antibiotic effective for the bacterial infection. Oral val acyclovir, this is suitable for mild or moderate VZV infection in the immunocompetent patient, but considering patient is having the very widespread VZV infection and the patient is also immunocompromised, so this is potentially a life-threatening disseminated infection, so oral val acyclovir, it would be less appropriate. Varicella zoster hyperimmune globulin, this is primarily used as a post-exposure prophylaxis in a high-risk individual who has been exposed to VZV, especially the immunocompromised patient, and this is not the treatment of choice in an active disseminated infection, so we'll be going for the IV acyclovir. Any patient who is taking prednisolone 40 milligram or more for longer than 7 days, or who is taking prednisolone 20 milligram or more for longer than 14 days is classed as immunocompromised. Patient taking lower doses of prednisolone or equivalent doses of other corticosteroid who are not classed as immunocompromised unless they are taking additional immunosuppressive medication. The presenting patient in this question has a primary chickenpox infection. Because he is immunocompromised, there is a high risk that this will progress to cause chickenpox pneumonia, which can be fatal. As he already appears to be systematically unwell, he needs IV rather than oral acyclovir. Oral valacyclovir or famciclovir would also be a reasonable option. There is no need to suspect a bacterial infection as at present, so flucloxacillin is not indicated. It's too late to give varicella zoster immunoglobulin because he has already developed a symptomatic infection. However, varicella zoster immunoglobulin could have been given within 7 days of his son developing chickenpox if the patient had sought medical attention at that time.
What is the most likely diagnosis? Dialysis-related amyloidosis, gout, primary hyperparathyroidism, secondary hyperparathyroidism, systemic sclerosis. 75-year-old man presented with widespread aches and pains. He had a 20-year history of hemodialysis for end-stage renal disease. X-ray of his hands was performed.
So this 75-year-old man has presented with a 20-year history of hemodialysis for ESRD, presenting with widespread aching and pains. So patient is having the long-term history of hemodialysis. So it indicates that the patient is having the CKD, which is often associating with multiple complications, including the bones and the mineral disorder. So if we analyze the X-ray findings, so look at the terminal phalanges. Any changes? Any changes in the terminal phalanges?
Some punched out.
So there is destruction of the terminal phalanges. This suggests that there has been the bony resorption, which is usually seen in condition affecting the bone metabolism, which is also seen in a patient with CKD. Now look at the first and the second phalanges. Any changes in first and second phalanges?
Periosteal reaction.
So there has been periosteal erosions. There has been periosteal erosion. This is also the classic finding in hyperparathyroidism, particularly in secondary hyperparathyroidism, where the elevated PTH, it usually leads to the bony resorption. And then look at the digital arteries. So any features of calcification? Yes or no?
Yes.
Yes, sir.
So there is vascular calcification, and this vascular calcification, this is also common in a CKD patient, particularly with those with the secondary hyperparathyroidism, where the chronic calcium and phosphate dysregulation contribute to this type of vascular calcification. So we are having destruction of the terminal phalanges, and we are having the subperiosteal erosion in the first and the second phalanges as well, and there is also vascular calcification involving the digital arteries. So most likely diagnosis, all these changes are found in case of secondary hyperparathyroidism. Okay, there would be destruction of the terminal phalanges, there would be subperiosteal erosion, and there will be vascular calcification. All of them are the classic findings of hyperparathyroidism, especially the secondary hyperparathyroidism. Also, what are the key points that is supporting the diagnosis of secondary hyperparathyroidism? So, number one, the patient is having the long-term history of hemodialysis and CKD. So, this is secondary hyperparathyroidism. This is a common complication in CKD, especially in a patient with long-term dialysis. And it occurs when the kidneys reduced ability to excrete the phosphate and produces the active vitamin D calcitriol, leading to hypocalcemia and compensatory hyperparathyroidism. And the subperiosteal bone resorption, this is the hallmark of secondary hyperparathyroidism, where there will be elevated PTH. The elevated PTH, it will cause the bony resorption, particularly in the phalanges. And the vascular calcification, these are also common in a patient with secondary hyperparathyroidism. So considering the radiographic features along with the long history of dialysis and the typical manifestation are highly suggestive of the secondary hyperparathyroidism. So if we analyze the other options, dialysis related amyloidosis, so it will typically comes up with the features of joint pain or with the features of carpal tunnel syndrome, and the radiographic findings here are the different, that is related to secondary hyperparathyroidism. In case of gout will have the joint pain erosion, and there would be well-defined pounced out lesion with the overhanging edge, and often with a soft tissue known as swelling known as the presence of tophi. Primary hyperparathyroidism can have the similar changes, but this patient is having the long-standing renal disease, and with the renal impairment, primary hyperparathyroidism is excluded. Systemic sclerosis. Systemic sclerosis can cause the vascular changes as well as the soft tissue calcification, but they are not associated with the subperiosteal bone resorption as well as the vascular calcification. So we have a distinct term. We have a distinct term known as the brown tumor. So this radiological feature be termed as brown tumor? The destruction of the terminal phalanges, subperiosteal erosion. Yes or no?
No. No.
Yes. So no. So this destruction of the terminal phalanges and the subperiosteal erosion and vascular calcification, these are the distinct features of secondary hyperparathyroidism. And brown tumor are the osteolytic bone lesion that occurs in hyperparathyroidism, and brown tumor can occur both in primary as well as secondary hyperparathyroidism, and it usually results from excessive osteoclastic activity and the bone resorption, and they are called brown due to the deposition of hemosiderin within the lesion, giving rise to a brownish appearance. And the brown tumor, they are usually seen in the context of severe and prolonged hyperparathyroidism, and typically they occur either in the ribs, pelvis, or in the long bone. They are less commonly seen in the small bones of the hand. So these are the distinct criteria of secondary hyperparathyroidism. So theoretically the brown tumor can also occur, but this X-ray finding, they are more typical of the secondary hyperparathyroidism. The image shows destruction of the terminal phalanges, subperiosteal erosion in the first and the second phalanges. These features are consistent with hyperparathyroidism. There is incidental vascular calcification in the digital arteries, which is common in ESRD. As the patient is having hemodialysis, the most likely diagnosis is secondary hyperparathyroidism as a result of deficient activation of vitamin D by the kidneys. Gout would result in destructive arthritis. Amyloidosis would not cause bone destruction, and systemic sclerosis would result in a soft tissue loss and probable calcinosis.
What is the most likely diagnosis? Alcohol-related cirrhosis, hemochromatosis, palindromic rheumatism, rheumatoid arthritis, sarcoidosis. 72-year-old man presented with a 4-year history of acute intermittent pain and swelling of his knees. The problem affected one knee at a time, and each episode lasted about a week. He took naproxen for the pain. His serum urate concentration was measured during one of the attacks and was found to be normal. He had drunk 24 to 28 units of alcohol per week for 30 years. There was no family history of diabetes mellitus. On examination, his BMI was 34 kg per meter square, his pulse was 64 beats per minute, and BP was 110 over 70 millimeters mercury. His liver was enlarged to 5 cm below the costal margin, and his spleen was 3 cm. The metacarpophalangeal joints of the index and middle fingers in both hands were swollen. Urine analysis showed glucose 3+. Hemoglobin was 165, WBC 9.5, platelets 135, serum sodium 128, potassium 3.1, urea 3.5, creatinine 56, albumin 31, total bilirubin 32, alanine aminotransferase 133, aspartate aminotransferase 110, and circulating plasma glucose was 13.4. What is the most likely diagnosis?
So given the combination of arthropathy, liver and spleen enlargement, abnormal liver function test, diabetes, and history of significant alcohol intake, so the hemochromatosis is the most likely diagnosis. So what are the key points in favor of the diagnosis? So number one is the features of arthropathy. So the patient joint symptom, it could be related to the hemochromatosis related arthropathy, which typically affects the second and the third metacarpal joint as seen in this patient, and in some cases there may be the involvement of the large joint like the knee joint as well, and this is usually characterized by the intermittent attack. And the pattern typical for hemochromatosis is where the iron deposition leads to arthritis, particularly affecting the MCP joint, and this is also known as the iron fist, since there is iron deposition that affects the MCP joint, and most commonly it involves the second and third MCP joint. And number two finding is the presence of hepatosplenomegaly. So the liver is enlarged to 5 cm below the costal margin and the spleen to 3 cm. So this hepatosplenomegaly, this is also consistent with hemochromatosis, where the iron deposition in this organ lead to hepatosplenomegaly. And number 3 point is the hyperglycemia. The fasting plasma glucose is significantly elevated, indicating diabetes mellitus, which is consistent with the bronze diabetes, a common complication of hemochromatosis, where there is iron deposition in the pancreas, leading to insulin deficiency. And number 4 point is the elevated transaminase. There is elevation of ALT and AST, indicating the hepatocellular injury, and which is often seen in case of hemochromatosis due to the iron overload. The patient is having the normal serum urea, normal serum urate level. So despite the symptoms resembling of the gout, the normal serum urate level during an acute attack, this is also making the gout less likely. Patient is having low sodium and low potassium. So this hyponatremia, hypokalemia, they are also seen in case of chronic liver disease, either due to fluid retention or secondary due to diuretic use or due to adrenal insufficiency. So regarding the hemochromatosis, so the classical signs would be cirrhosis due to hepatic involvement. There would be diabetes mellitus, also known as the bronze diabetes, due to pancreatic involvement. There will be bronze skin pigmentation due to the iron deposition, and there should be typical arthropathy, especially involving the MCP joint known as the iron fist, and there should be organomegaly, hepatomegaly, and splenomegaly. So what should be the investigation of choice in case of hemochromatosis?
Transferrin saturation.
So we'll be going for both serum ferritin and transferrin saturation measurement, and both of them is expected to be elevated. And for the confirmatory diagnosis, HFE.
Genetic testing.
Yes, we'll be going for the genetic testing, HFE, genetic mutation. So for general population, we'll be going for ferritin and transferrin saturation, and in the family member, we'll be going for the HFE genetic testing. And two type of mutation are found. One is C28Y and another one is the ACE63D. So which one is more common, 282 or 63D?
282.
Yeah, 282, this mutation is most common. And what should be the definitive management for hemochromatosis, especially the hereditary?
Venesection.
Yes, we'll be going for the venesection. What are the other indication of venesection? Polycythemia rubra vera and the
Hereditary spherocytosis.
not hereditary
And
spherocytosis,
thalassemia.
hereditary hemochromatosis. Another one is the PCT, porphyria cutanea tarda. And this hemochromatosis is one of the risk factor for the development of pseudo gout. What are the other risk factors?
Hypomagnesemia.
Hypomagnesemia, hemochromatosis, Wilson's disease, low phosphate, low magnesium, hyperparathyroidism. And the PPI also leads to hypomagnesemia. So PPI can also lead to pseudogout, but the most common risk factor is the hemochromatosis. So if we consider the other options, so alcohol related cirrhosis. So patient is having the liver enlargement and abnormal liver function test. It could suggest cirrhosis, but the absence of other signs of decompensated CAD like the ascites, jaundice, encephalopathy, and the specific joint involvement like the MCP joint, this is more suggestive of the hemochromatosis. And this cirrhosis, it does not typically causes the pattern of joint disease, and alcohol use can contribute to liver disease, but the joint symptoms and the diabetes, they are better explained by the hemochromatosis. Palindromic rheumatism, so it causes the episodic joint inflammation, often symmetrical, and it usually does not lead to the chronic changes that is being presented here regarding the MCP joint. And this is not also associated with the liver disease, diabetes, or splenomegaly. So the systemic sign of hepatic enlargement, diabetes, splenomegaly, this is also excluding the palindromic rheumatism. Rheumatoid arthritis, it can affect the MCP joint, but they will usually comes up with the symmetrical polyarthritis, and this is not episodic. And this patient is having the intermittent joint pain. And rheumatoid arthritis also does not associate with the hepatic enlargement or hyperglycemia unless the patient is treated for long-term steroid use. And also the specific pattern of hepatocellular damage are also not seen in rheumatoid arthritis. And rheumatoid arthritis will also comes up with the elevated inflammatory markers, but the WCC count here is normal, and we would be expecting a positive rheumatoid factor, which is also absent here. Sarcoidosis can affect the multiple organ system, including the liver, but it usually does not cause the hepatosplenomegaly, and they are usually related to the respiratory or the constitutional symptoms. Joint pain involvement can occur in sarcoidosis, but it will typically involve the large joint. It usually does not involve the MCP joint, and most of the features would be related to the pulmonary involvement. So this is our hemochromatosis. This is a question about episodic inflammatory arthritis. The most common reason for this would be crystal arthritis, either gout or pseudogout. The serum uric acid is normal. It can be normal in both of the conditions. The history of alcohol intake is perhaps tipping us towards gout as being a more likely possibility. However, when we get further information that this man also has MCP involvement with hepatosplenomegaly, type 2 diabetes mellitus, it does point us in the direction of this being more systemic problem. Going with the options, the only plausible one is hemochromatosis, which can produce an episodic arthritis of this type. Alcohol-related cirrhosis does not have a definitive association with any crystal arthritis. Palindromic rheumatism and rheumatoid arthritis are symmetrical. The arthritis of sarcoidosis is typically in a large joint and in a younger age group. Therefore, the best answer is hemochromatosis, leading to chondrocalcinosis and pseudogout.
What is the most appropriate treatment to reduce his risk of recurrent pancreatitis? Atorvastatin, ciprofibrate, ezetimibe, nicotinic acid, omega-3 acid ethyl esters. 42-year-old man was admitted to hospital with severe abdominal pain. His alcohol intake was 18 units per week. His serum amylase concentration was raised at 1346 units per liter, and a diagnosis of acute pancreatitis was made. There was no evidence of gallstones. He made an uncomplicated recovery. Investigations after recovery showed fasting plasma glucose 5.7, serum cholesterol 5.8, non-HDL cholesterol 3.41, HDL cholesterol 0.96, and fasting serum triglycerides 22.63. What is the most appropriate treatment to reduce his risk of recurrent pancreatitis?
So this patient has presented with severe abdominal pain in the context of significant elevation in the serum amylase concentration, which is highly suggestive of acute pancreatitis. The alcohol intake is 18 units per week, so this is within the normal range, and excessive alcohol intake can lead contribute to pancreatitis, but since the level is within the normal range, so this is less likely that alcohol intake has led to the pancreatitis. And if we look for the post recovery lipid profile, so fasting plasma glucose is normal, meaning there is no diabetes. Serum cholesterol level is slightly elevated. Serum non-HDL cholesterol is slightly elevated. The HDL level is reduced. The fasting serum triglyceride level is significantly elevated. So most likely this is the severe hypertriglyceridemia associated pancreatitis. So in case of severe hyperglyceridemia associated pancreatitis, patient will have significant hypertriglyceridemia. This is one of the well-established cause of acute pancreatitis, and it will also increases the risk of pancreatitis due to the release of fatty acid from the triglyceride-rich lipoprotein, which can also cause the pancreatic injury. And also there is no evidence of gallstone, so this is shifting our focus from the gallstone causing pancreas to the hypertriglyceridemia associated pancreatitis. So for the most appropriate treatment, we need to fulfill two criteria. We'll reduce the triglyceride level. It will be critical to prevent the recurrent episodes of pancreatitis. And we also need to address the additional dyslipidemia. So which one should be the most appropriate treatment here?
Fibrates.
Yes, we'll be going for the fibrate. So ciprofibrate, it falls under the fibrate class. Also fibrate, it reduces the triglyceride level by activating the PPAR alpha, peroxisome proliferator activated receptor alpha, which will causes increases the expression of enzyme involved in lipid metabolism like the lipoprotein lipase. And it will also enhance the triglyceride clearance from the blood by increasing the breakdown of triglyceride rich particles like the VLDL. And this ciprofloxacin, this is the most potent class of medication for reducing the triglyceride level, particularly in cases of severe hypertriglyceridemia. It also increases the HDL cholesterol, and it also causes modest reduction of the LDL cholesterol. And regarding atorvastatin, so it falls under the class statin. It primarily lowers the LDL cholesterol by inhibiting the HMG CoA reductase, the enzyme responsible for the cholesterol synthesis in the liver. Atorvastatin can reduce triglyceride, but this is usually effective for mild to moderate reduction of triglyceride, and this is also not the first line therapy in case of severe hypertriglyceridemia. This is more effective in managing the high LDL cholesterol and also preventing the cardiovascular disease. The azitimib. So azitimib is the cholesterol absorption inhibitor. This reduces the absorption of cholesterol from the small intestine, and it will lower the LDL cholesterol, and it also has a little to no effect on triglyceride. This is more effective in reduction of the LDL cholesterol on the top of statin therapy. Nicotinic acid, also known as the niacin, this is our vitamin B3 derivative, and it reduces the production of VLDL, the very low density lipoprotein in the liver, and it will lower the both LDL cholesterol and the triglyceride. But this is also not so much effective like the ciprofloxacin in the management of severe hypertriglyceridemia. This is usually advocated when there is a very mild profile. Omega-3 acid ethyl ester, so this falls under the omega-3 fatty acid. It reduces the hepatic triglyceride production, and it also increases the triglyceride clearance. But if we compare this one with the ciprofloxacin is the most potent. This omega-3 acid steroid, it can be used as an adjunctive therapy, but this is not the first line therapy for severe hypertriglyceridemia. This man's presentation of acute pancreatitis was most likely due to hypertriglyceridemia. He does not have evidence of gallstone or diabetes. His alcohol intake is not excessive. His non-HDL cholesterol is only moderately elevated. All the drugs except azitimib lower triglyceride to some degree, but fibrate are the most effective and thus most appropriate.
What is the most likely explanation for the CT appearance? Ascites, constipation, hepatocellular carcinoma, pseudomyxoma peritonei, retroperitoneal hemorrhage. A 40-year-old woman was investigated for increasing abdominal girth, nausea, and alteration of bowel habit. On examination, her abdomen was distended and generally dull to percussion. Investigation showed CT scan of the abdomen is shown below.
So most likely explanation for the CT appearance. So given the clinical scenario, the most likely explanation for the CT appearance is the pseudomyxoma peritonei. So this is one of the rare condition which often originates from the mucin producing tumor, usually from the appendix or in some cases from the ovary. And the tumor cell, they will secrete the mucin into the peritoneal cavity, and it will ultimately lead to accumulation of the jelly like substance which appears as which appears as hypoattenuated or appears as blackish, and it will slowly fill the abdomen over time, and for this reason this condition is also known as the jelly belly. So why pseudomyxoma peritoneae is the best explanation? So number one, regarding the clinical presentation. So this patient has presented with increasing abdominal girth, abdominal distension, nausea, and alteration of the bowel habit. Increasing abdominal girth and distension. This is due to the mucin accumulation within the peritoneal cavity. And the most common finding both in male and female in case of pseudomyxoma peritoneum would be increasing the abdominal girth. And next most common in the male patient would be inguinal hernia, and next most common in female patient would be either bilateral or unilateral ovarian mass. And this type of patient will also have the alteration of the bowel habit as the growing mucinous materials compresses or displaces the intestine. And on examination, the abdomen is distended and generally dull to percussion, which suggests that there is presence of either a large volume of fluid or mass within the abdomen. So normally the abdomen, it will sound hollow when percussed because it will contains the gas filled intestine. And dullness to percussion in pseudomyxoma peritoneae is most likely due to displacement of the gas filled intestine by the mucin. And regarding the CT appearance, so on the CT they will appear as an low density areas. This type of low density blackish areas representing mucin or representing jelly belly, and it will scallop or compress the adjacent structure like the liver, and it will causes compression of the spleen as well as the intestine. And the mucins are often the loculated, they are often loculated, and it also causes the significant abdominal distension, and there will be characteristic jelly like materials within the peritoneal cavity causing the extrinsic compression of the abdominal organ, which is the hallmark of the condition. And this picture is a little bit difficult one. Let me show you some of the classical pictures. So this is our axial CT contrast abdomen and the pelvis. So this you can see that there is multiple lobulated. Look at the arrow marks. There is multiple lobulated low attenuation soft tissue mass due to the mucin deposition, which is scalloping the borders of the liver, borders of the pancreas, as well as the mesentery. So axial contrast CT image of the abdomen and pelvis demonstrate lobulated low attenuation soft tissue mass scalloping the borders of the liver, spleen, and along the mesentery. So they will be lobulated and they will cause extrinsic compression, especially liver, pancreas, and the intestine. So there will be extrinsic compression. Diffuse collection of gelatinous material in the abdomen and pelvis and mucinous implants on the peritoneal surface results in a massification organ, also known as the jelly belly. So look at the next picture here. So hypoattenuated liver compression, liver scalloping. There is peritoneal nodule. There is features of peritoneal thickening. So this is another axial CT contrast abdomen. So you can see that the hypoattenuated, typical excessive scalloping of the liver and the spleen by the intraperitoneal mucin. So compression of the liver as well as the spleen. So there is also multiple hypoattenuated mass-like lesion with loculated fluid within the peritoneum and the omentum mesentery, and it is also causing the extrinsic compression. Features of CT scan and extensive scalloping of the liver suggest rupture of a mucinous neoplasm resulting in the pseudomyxoma peritoneae. There are multiple low attenuating mass-like lesion with loculated fluid throughout the peritoneum, omentum, mesentery, accompanied by scalloping of the visceral surface, particularly the liver. So the surface has been compressed or scalloped. So same picture in the axial non-contrast, you can see the scalloping or compression, and they are hypoattenuated and multiple loculated. So the same picture in the axial contrast, portal venous space, the compression and the multiple loculation. And the same picture in axial contrast, delayed phase. And this is coronal contrast, portal venous space. So you can also see the compression and hypoattenuated and multiple loculated. This is the sagittal contrast, portal venous phase. And so this picture is a little bit atypical, but you can memorize this type of picture. Whenever there is hypoattenuated collection with multiple lobulated, compressing the organs of the peritoneal cavity with increasing abdominal gut, nausea and alteration of the bowel, most likely diagnosis is the pseudomyxema peritoni. So let's analyze the other options. So ascites. So ascites can also causes the abdominal distension, dullness and percussion, and this is usually associated with the either hepatic cirrhosis, heart failure or malignancy. And it will also appear as a free fluid within the peritoneal cavity, and it will not causes compression or scalloping of the intraperitoneal organ. And if you go for the CT scan, due to the gravitational distribution, they will collect on the most dependent part of the abdomen, meaning in the flank when the patient will be lying down. And it also typically does not forms the loculated collection or compression of the organs. And also if we consider ascites, there should be additional features of CLD or the heart failure. Regarding constipation, so constipation on the CT scan, they will show a large amount of stool in the colon, and there won't be widespread low density material in the peritoneal cavity, and it will not also causes the extraluminal changes, or it will also not causes a compression of the other organs. And constipation, it can cause abdominal discomfort, distension or bloating, but it will not usually causes significant increase in the abdominal gut or the degree of generalized dullness to percussion without corresponding bowel sound or the gas distribution changes. Hepatocellular carcinoma, it usually presents as a mass or multiple masses within the liver parenchyma, meaning it would be intrahepatic. The lesion would be intrahepatic lesion, and sometimes it may be surrounded by ascites, or there may be hepatic enlargement in the advanced cases. And the scalloping or the diffuse patterns in here, this is more suggestive of the pseudomyxoma peritoni. Regarding retroperitoneal hemorrhage, so this usually occurs as a result of either trauma, ruptured aneurysm or anticoagulation, and there would be blood collection within the retroperitoneal space. So patient will come up with the features of severe pain and along with the features of shock, rather than slow progression of the abdominal distension or gradual increase. And if you go for the CT scan, then it will show the localized collection of blood in the retroperitoneum, and it may also displace the organs anteriorly, but it will not causes the diffuse distribution of mucin, and it will not also causes the intraperitoneal organ compression. And the gradual abdominal distension, alteration of the bowel habit, it also does not it cannot be explained by retroperitoneal hemorrhage. So this is our pseudomyxoma peritoni. This is a difficult question, as pseudomyxoma peritoni is extremely rare and such an image is highly unusual. However, the correct answer can be deducted by the process of elimination. Ascites would have a gravitational distribution, could not be loculated around the liver in this way. Constipation is clearly incorrect, as this could not produce this extraluminal changes. Hepatocellular carcinoma can produce multifocal intrahepatic lesion, but in this image, most of the abnormalities are clearly seen to be compressing the liver from outside, suggesting an extrahepatic cause. Retroperitoneal hemorrhage of sufficient magnitude to cause these changes would not be compatible with the patient's history.
What is the most likely diagnosis? Antiphospholipid antibody syndrome, calciphylaxis, cholesterol embolization, coumarin necrosis, thromboembolism from AV fistula. A 65-year-old man had a 10-year history of dialysis dependent end-stage renal disease caused by renovascular disease. He began taking warfarin because of recurrent AV fistula thrombosis. 1 month later, he presented with a livedo radicularis on his trunk and areas of painful ulceration on his shins. Hemoglobin was 102, WBC 5.4, eosinophils 0.78, platelet count 478, INR 1.9, serum corrected calcium 2.58, serum phosphate 1.90. Plasma parathyroid hormone 18.5, anticardiolipin IgG antibodies 32, and anticardiolipin IgM antibodies 24. What is the most likely diagnosis?
Oh, so this is a difficult one. So how many of you think it can be calciphylaxis? And how many of you think it can be cholesterol embolization? Is it calciphylaxis or cholesterol embolization? So the most likely diagnosis is the cholesterol embolization. So if we go for the clinical presentation, so this patient is having the history of atheromatous vascular disease, the renovascular disease, and dialysis dependent end-stage renal disease, and was started on the warfarin therapy due to recurrent AV fistula thrombosis. And after starting the warfarin, he developed the livedo reticularis, a motile net-like pattern on the skin on the trunk, and there is painful ulceration on the shin, which are classic signs of the cholesterol embolization. And this condition, this is often precipitated by anticoagulation or following the PCI, which can dislodge the cholesterol crystal from the atherosclerotic plaque, leading to emboli that occlude the small vessel. And this painful ulceration on the shin, this is consistent with the ischemic changes caused by the emboli. And if we analyze the laboratory findings, so patient is having the features of eosinophilia, and this is the key indicator. This is the cardinal features of cholesterol embolization. And eosinophilia in cholesterol embolization, it usually occurs due to inflammatory response to the cholesterol crystal in the blood vessel. There is features of thrombocytosis, which explain the reactive process in response to vascular injury. The patient INR is within the therapeutic range, which indicates that warfarin is not excessively anticoagulating the patient. Rather, the anticoagulation itself might have triggered the embolization. And regarding the additional findings, so patient is having the anticardiolipin antibodies positivity, so it may suggest that patient may have the antiphospholipid antibody syndrome, but the levels are relatively low, and these are also not the definitive for the antiphospholipid antibody syndrome. And also the presence of livedo reticularis and ulceration in the context of recent warfarin initiation and the known vascular disease, they points more towards the cholesterol embolization than the antiphospholipid antibody syndrome. The calcium phosphate and the PTH level, they are also abnormal, indicating there may be bone mineral disease secondary to CKD, which is common in a patient with ESRD, but it's not specific for the underlying condition. So why not the other diagnosis? So regarding antiphospholipid antibody syndrome, so antiphospholipid antibody syndrome, they may have the elevated anticardiolipin antibodies, which is one of the criteria for antiphospholipid antibody syndrome. and they may also have the livedo reticularis. But the skin ulceration described here, they are typically resulting from the thrombotic events. No, and these ulcers are usually secondary to the small vessel thrombosis. And the presence of eosinophilia, elevated eosinophil count, this is not also found in a patient with antiphospholipid antibody syndrome, and this patient will have the history of either a thrombophilic event, or there should be history of the recurrent miscarriage rather than eosinophilia. And the EPS usually presents with multiple thrombotic events, and these are not usually related following the warfarin initiation. Regarding the coumarin necrosis, so this is coumarin necrosis. This is one of the potential complication of warfarin therapy and could present with skin necrosis. But this warfarin necrosis typically presents with painful, well demarcated necrosis within the first 2 weeks of starting warfarin, or more specifically within 3 to 8 days of warfarin initiation. But here the patient has presented after 1 month following the warfarin. And the normal INR also indicating that warfarin is within the therapeutic range. And coumarin necrosis are usually sharply demarcated, painless and necrotic plaques that are usually found in the high subcutaneous fat like the breast, thigh, or the buttocks. And livedo reticularis will also not be the findings. And coumarin necrosis also does not come up with the features of eosinophilia. Thromboembolism from arteriovenous fistula. So this patient has a history of arteriovenous fistula thrombosis, so it can be considered, but it will causes the distal ischemic changes and not the widespread livedo reticularis or ulceration. And the eosinophilia can also not be explained by this. So in case of thromboembolism from arteriovenous fistula, it will likely lead to ischemia in the limb in the downstream from the fistula rather than the widespread skin manifestation. And also the absence of acute symptoms of ischemia, this is also excluding the thromboembolism from arteriovenous fistula. And regarding the calciphylaxis, so this is one of the serious condition that occurs in patient with end-stage renal disease, and patient usually comes up with the painful skin ulceration or nodule. And this patient has the ESRD, elevated phosphate, elevated PTH. So these are also the risk factor for calciphylaxis. But calciphylaxis usually comes up with very severe tender violaceous subcutaneous nodule, which may ultimately progress to necrotic ulceration. But this ulceration, they are usually located to the thigh, abdomen, and the buttocks. They usually does not present as an widespread livedo reticularis. The eosinophilia is also not found in calciphylaxis, and they usually comes up with necrotic and gangrenous type of ulceration rather than the inflammatory pattern of ulcerations in case of cholesterol embolization. So the combination of livedo reticularis, painful ulceration, eosinophilia, recent warfarin therapy in a patient with ESRD, and the vasculitis, this is strongly suggestive of the cholesterol embolization, and this usually occurs due to dislodgement of the cholesterol crystal from the atherosclerotic plaque, which usually embolizes the small vessel, causing systemic ischemia and the inflammatory reaction. And this is typically precipitated either by anticoagulation or following the invasive vascular procedure like the PCI, percutaneous coronary intervention. And cholesterol embolization, they will comes up with the features of PARL. So what is the elaboration of PARL? PEARL. So P for purpura, E for eosinophilia, A for arteriopath like the abdominal aortic artery aneurysm, R for renal failure, meaning post CABG patient, or there should be livedo reticularis. And livedo reticularis and eosinophilia, these two are the cardinal features. So this is our cholesterol embolization. And cholesterol embolization is very important for the exam. You will get at least one question in every diet. The development of levator reticularis, skin ulceration, eosinophilia in a patient with atheromatous vascular disease who has recently started taking warfarin, is highly suggestive of cholesterol embolization. None of the other conditions is usually associated with eosinophilia. The patient has a low levels of anti-cardiolipin antibodies, but these are present in up to 10% of general population, are not diagnostic of antiphospholipid antibody syndrome. In addition, antiphospholipid antibody syndrome does not usually cause skin ulceration. Calciphylaxis usually starts as tender violaceous subcutaneous nodule, which progresses to necrotic ulceration. Coumarin necrosis typically occurs within 2 weeks of starting warfarin. Thromboembolism from arteriovenous fistula would not cause skin changes in the trunk or legs.
What is the most appropriate next investigation? CTPA, D-dimer, echocardiography, ultrasound scan of legs and pelvis, ventilation perfusion isotope lung scan. A 27-year-old woman attended the ED with a 1-week history of progressive dyspnea and cough and a 2-day history of left basal thoracic pain on inspiration and hemoptysis. She had a history of bronchiectasis. She was a non-smoker. She had recently returned from a holiday in New Zealand and was taking co-amoxiclav and prednisolone prescribed by her GP for an exacerbation of her bronchiectasis. She was a non-smoker. On examination, she was thin. Her temperature was 37.3 degrees Celsius. Pulse was 115 beats per minute and regular. BP was 128/78 millimeters mercury. Respiratory rate was 22 breaths per minute. Further examination was normal. On investigation, hemoglobin was 157, WBC 18, serum CRP 68. ABG gases on breathing air were PO2 8.9, PCO2 4.9, pH 7.4, H plus 40, and bicarbs 22. ECG showed sinus tachycardia, and chest X-ray showed cystic changes on the left base. What is the most appropriate next investigation?
So most likely diagnosis. So this presentation of the young woman with history of bronchiectasis who has developed progressive dyspnea, pleuritic chest pain, hemoptysis, and this clinical findings combined with a history of recent travel and the presence of sinus tachycardia. It raises the possibility of a most likely the underlying pulmonary embolism. So if we consider the key points in favor of the diagnosis, so number one, there is a recent history of travel. So patient has recently returned from a long flight, which usually increases the chance of deep-vein thrombosis as well as the subsequent pulmonary embolism. Patient has comes up with the features of dyspnea, and also there is a pleuritic chest pain. And this dyspnea and the pleuritic chest pain, these are the classical symptoms of pulmonary embolism. In some cases, patient may also comes up with the features of hemoptysis, but this is usually less commonly found. And there is also evidence of sinus tachycardia. So although this is a non-specific finding, but this is commonly seen in a patient with pulmonary embolism. And if we go for the ABC, there is a mild hypoxemia without hypercapnia, and hypoxia is usually found in a patient with pulmonary embolism. And this mild hypoxemia without hypercapnia, this is reflecting the ventilation perfusion mismatch. There is also elevated white cell count, so it can be explained. It indicates an inflammatory response, which could be due to the his patients having the bronchiectasis exacerbation, but it can also be explained by the thromboembolic event, like the embolic event causing the lung infarction. And the chest X-ray is showing the cystic changes in the left lung bases, so it may be explained by either bronchiectasis and pneumonia. So the most likely diagnosis is the pulmonary embolism. Other differential can be like the infective exacerbation of bronchiectasis or pneumonia. So what should be the most appropriate next investigation? if we consider pulmonary embolism or infective exacerbation of bronchiectasis, which one would be the most appropriate next investigation?
CTPA.
Yes, we'll be going for the CTPA. CTPA is the gold standard imaging modality for diagnosing pulmonary embolism, and it usually directly visualizes the emboli in the pulmonary arteries. And with the combination of her symptoms of recent travel, sinus tachycardia, mild hypoxemia, it suggests the high clinical probability for the pulmonary embolism. So in such context, you should be going for the immediate imaging to confirm the diagnosis and guide for the treatment. And bronchiectasis can also have some of the baseline abnormalities on the chest X-ray, but this is looking more likely the pulmonary embolism. So CTP would be the most likely next investigation. And regarding other options, so D-dimer. So D-dimer testing, it can be helpful in ruling out pulmonary embolism in patient with a low clinical probability, but this patient is having high clinical probability. And the D-dimer test would not be appropriate here because the negative result would not rule out pulmonary embolism definitively, and positive result would only lead to the further imaging of CTPA. Regarding echocardiography, so this is useful in assessing the right heart stent secondary to either massive pulmonary embolism, but it will not directly diagnose the pulmonary embolism, and as it cannot directly visualize the pulmonary artery. It might be indicated later on if the CTPA shows a large pulmonary embolism, or if the patient deteriorate, or if there is any features of hemodynamic instability, but the patient is hemodynamically stable. Ultrasound scan of the legs and pelvis. This is usually used to diagnose the deep vein thrombosis, which can lead to the pulmonary embolism, but it will not diagnose the pulmonary embolism itself. The ventilation perfusion isotope lung scan, the VQ scan, this is an alternative to CTP, and usually the CTP is the first line, and CTP is the gold standard imaging modality. We'll only go for the VQ scan if the patient cannot receive the contrast due to either renal impairment or due to contrast allergy. And also the CTP is preferred because it is more specific, and it will directly visualize the emboli, and it will also show the other potential causes of the symptoms. So CTP would be the most appropriate next step because it will directly visualize the pulmonary emboli and confirm the diagnosis. The clinical presentation history and the recent travel strongly suggest pulmonary embolism, making CTPA the most suitable and effective test to proceed with to either confirm or rule out the diagnosis. So we'll be going for CTPA.
Sorry, please, can't see your screen.
Sorry, please.
Screen. Sorry, I can't see your screen. I don't know if it's from my end.
Others can see the screen.
Yes, sir, we can see.
Okay. The main differential lies between pulmonary embolism and exacerbation of our bronchiectasis with the developing left lower lobe pneumonia. CT pulmonary angiography, CTPA, allows imaging of both pulmonary vasculature and the lung parenchyma and is the correct answer. D-dimer is non-specific, used as a test of exclusion when thromboembolism is considered, but is not a diagnostic test. And echocardiogram is unlikely to show any right ventricular dilatation or intracardiac thrombus in the absence of cardiovascular collapse. And ultrasound scan will at best give circumstantial evidence of thromboembolic disease. Our ventilation perfusion isotope lung scan would be indeterminate at best in the context of underlying airway disease or bronchiectasis, and thus will not help with a definitive diagnosis of thromboembolic disease.
What is the most appropriate treatment? Oral flucloxacillin, oral prednisolone, radiotherapy, surgical debridement, topical terbinafine. A 30-year-old woman had a 3-year history of Crohn's disease, which had required the formation of an ileostomy. She presented with a sore area around the stoma, seen in the image. This was causing problems with adhesion of the stoma pouch.
So this 30-year-old woman with a 3-year history of Crohn's disease, which required an ileostomy, presented with a sore area around the stoma, causing problems with adhesion of the stoma pouch. So most likely diagnosis.
Pyoderma gangrenosum.
So this pyoderma gangrenosum, this is an inflammatory skin disorder which is commonly associated in a patient with IBD or in a patient with Crohn's disease, and patient usually comes up with the painful ulceration. There will be well demarcated full thickness skin ulceration around the stoma. So well demarcated full thickness skin ulceration, and the ulcerations are often punched out appearance, and there will be violaceous this type of purple colored erythema, and there may be some of the sloughs at the edges, but typically there would be no other overt sign of infection. And this is commonly associated with the Crohn's disease, and it can develop around the areas of trauma or surgery, such as the stoma site, due to the phenomenon known as the Koebner's phenomenon. So what should be the first line choice if pyoderma gangrenosum is suspected?
Oral prednisolone.
Yes, we'll be going for the oral prednisolone. The treatment of choice for pyoderma gangrenosum would be the systemic corticosteroid, like the oral corticosteroid. And because this condition, this is driven by the abnormal immune response, and the corticosteroid, it will help to reduce the inflammation as well as the immune activity. So regarding other options, so oral flucloxacillin, this is typically used to treat the staphylococcal skin infection, which is common in the periostemal skin due to irritation or moisture. If the bacterial areas was suspected to be, if the sore area was suspected to be due to bacterial infection, then in that case we can go for the oral flucloxacillin, but there is no features of active infection, bacterial infection here. Radiotherapy, this is not applicable for treating the stoma site, sore site around the stoma, especially in the context of Crohn's disease. Surgical debridement, this is usually reserved for necrotic or severely infected tissue, typically when there is evidence of significant tissue death or non-healing old ulcer. And this surgical debridement, it will also causes worsening of the pyoderma gangrenosum due to the pathology phenomena, due to the when there is minor trauma, there will be exacerbation of the condition. So surgical debridement will causes further deterioration of the pyoderma gangrenosum. Topical terbinafine, this is the antifungal treatment. So it would be appropriate if the sore area was suspected to be fungal in origin. In that case, there would be erythematous pruritic lesion with formation of satellite pustules. So this is the typical case of pyoderma gangrenosum. So the first line choice of treatment should be oral, systemic oral steroid, oral prednisolone. And what is the definitive management? Definitive management of pyoderma gangrenosum, we'll be going for anti-TNF, subcutaneous anti-TNF. Which anti-TNF is commonly used?
Infliximab.
Yes, infliximab is commonly used. I for infliximab, I for IBD. So oral prednisolone followed by subcutaneous infliximab. This image shows well demarcated full thickness skin ulceration around the stoma. There is a little slab peripherally, no overt features of bacterial infection. The ulcer is about punched out appearance. The wound is reverse violaceous erythema. These are features of pyoderma gangrenosum, which is a recognized complication of Crohn's disease. The involvement of peristomal skin is quite common, possibly representing a Koebner's phenomenon. Initial treatment is with the oral prednisolone.
What is the most likely diagnosis? Alcohol excess, folate deficiency, hypothyroidism, pernicious anemia, polymyositis. A 48-year-old woman complained of leg weakness and tenderness, which was worse on exercise. On investigation, hemoglobin was 118, MCV 101, serum creatinine kinase 740, anti-thyroid peroxidase antibodies positive, anti-gastric parietal cell antibodies positive, and ANA was negative. What is the most likely diagnosis?
So the most likely diagnosis for this 48-year-old woman presenting with the leg weakness, tenderness, elevated creatinine kinase, and positive anti-thyroid peroxidase antibodies and positive anti-gastric parietal cell antibodies. The most likely diagnosis is the hypothyroidism. So what are the key points? So regarding the symptoms, patient is having leg weakness and tenderness. So these are the common symptoms of muscle involvement, which can occur in various conditions, including hypothyroidism. So in case of hypothyroidism, there is a specific term known as the hypothyroid myopathy. The muscles will become stiff, weak, and tender, particularly on exertion. And Orson exercise, meaning it also suggests the myopathic process where the muscle fatigue and pain are more pronounced following the exertion. And regarding the investigation, patient is having the elevated creatinine kinase. Elevated CK, this is often seen in hypothyroid myopathy due to an underactive thyroid, where the muscle breakdown will release the creatine CK into the bloodstream. Patient is having features of macrocytic anemia, and hypothyroid can cause macrocytic anemia due to impaired RBC production. But it can also be explained by other conditions like the folate deficiency as well as the pernicious anemia. Positive anti-TP antibody. This is strongly suggestive of the autoimmune thyroid disease, most commonly the Hashimoto's thyroiditis, which is the most common cause of hypothyroidism. Positive anti-gastric parietal cell antibodies. This is seen in the autoimmune condition, including those with the autoimmune hypothyroidism, and it can also be seen in case of pernicious anemia. But only the isolated presence of anti-gastric parietal cell antibody without other systemic or neurological presentation, this is less suggestive of the pernicious anemia. And the ANA is also negative here. So ANA is often positive in autoimmune disease like the SLE or in case of polymyositis. So this is also making polymyositis less likely. So most likely diagnosis is the hypothyroidism. So now if we consider other options, so alcohol excess or alcohol abuse can cause the muscle pain and elevated creatinine kinase, but the presence of autoimmune antibodies like the TPO and anti-gastric parietal cell antibodies and the macrocytic anemia, they are not consistent with the alcohol excess. Folate deficiency can cause a macrocytic anemia, but it will not cause elevation in creatinine kinase or features of myopathy. Pernicious anemia, it will comes up with the macrocytic anemia, and it will comes up with the features of anti-gastric parietal cell antibodies. But pernicious anemia, it won't be typically associated with elevated creatinine kinase or features of myopathy. There should be potentially more severe neurological symptoms coming up with the features of subacute combined degeneration of the spinal cord. And the anti-TPO antibody, this is not also less likely to this is found in autoimmune conditions, so it can also be seen as a part of other autoimmune condition. Polymyositis, this is the inflammatory muscle disease, and it will cause a significant elevation in the creatinine kinase at least greater than 1000, and there should be proximal muscle weakness. So polymyositis usually comes up with the features of painless, painless progressive proximal muscle weakness, and the absence of ANA and the presence of TPO antibodies. It is also making the polymyositis less likely. So let me show you the polymyositis. How to treat a case of polymyositis? Treatment.
Prednisolone.
Yes, we'll be going for
Prednisolone.
the prednisolone. What is polymyositis? So polymyositis will comes with the features of lots of P. Polymyositis classically presents with relatively painless progressive proximal muscle weakness. So in some cases, this is written that polymyositis may be slightly painful as well, but the cardinal feature is this is usually painless. The proximal myopathy and raised creatinine kinase at least greater than 1000 in the absence of viruses suggest polymyositis is the most likely diagnosis. And weakness and muscle pain are the predominant features of polymyositis. So in one place this is written as muscle pain, and in another place this is written as painless. So we'll be going for the hypothyroidism. The positive antibodies suggest autoimmune endocrinopathy. Of the two options, pernicious anemia would not cause an elevated creatinine kinase. Polymyositis is much less likely with a creatinine kinase less than 1000. Folate deficiency and alcohol excess might explain the raised MCV and weakness, but the most likely diagnosis is the hypothyroidism. CK is modestly elevated, less than 10 times upper limit of normal in up to 90% of untreated patients. Up to 79% complaints of muscle symptoms. A raised MCP may represent concomitant pernicious anemia, but also occurs in about 10% of hypothyroid patients who have normal vitamin B12 level for reasons that are unclear. Her symptoms should improve with the thyroid replacement.
What is the most appropriate management? Amiodarone, digoxin, no intervention, permanent pacemaker, warfarin. An 82-year-old woman presented to the ED following a fall. She did not have any loss of consciousness. She had a history of type 2 diabetes mellitus, osteoarthritis of her hips and spine, diverticular disease, and a hiatus hernia. Her medication comprised gliclazide, ibuprofen, omeprazole, isoflurane husk, and paracetamol. On examination, she appeared well and had no signs of pain. A 24-hour ECG showed normal sinus rhythm throughout, with a daytime heart rate of 60 to 100 beats per minute and a nighttime heart rate of 42 to 58 beats per minute. There were frequent ventricular and supraventricular ectopic beats, one short run 5 beats of AF, and one pause of 2 seconds duration at 5:30 hours. No symptoms were noted. What is the most appropriate management?
So the most appropriate management for this 82-year-old woman presented after a fall but had no signs of injury and a normal sinus rhythm throughout 24-hour ECG with some notable findings such as the nighttime heart rate that dropped to 42 to 58 beats per minute, frequent ventricular and supraventricular ectopics, and a brief episode of atrial fibrillation 5 beats, and a 2-second pause at 5:30 am. So most appropriate management or intervention would be the no intervention. So if we analyze the clinical context, so if we consider the age and the history of fall, so the patient is elderly and presented after a fall, but she did not lose the consciousness and there were no signs of injury. And this patient has the type 2 diabetes, osteoarthritis, diverticular disease, hiatus hernia, and her medication are not particularly concerning for cardiovascular issues. except ibuprofen may have some of the cardiovascular risk, but other than this, all of them are particularly not concerning. And regarding 24-hour ECG findings, so there is a normal sinus rhythm which is reassuring, and there is no significant arrhythmia present. The heart rate is within the acceptable range for our age, 60 to 100 beat per minute during the day and 40 to 58 beat at night. A nighttime heart rate on the lower side is common, and this is not often concerning in an elderly patient unless this is symptomatic. Patient is also having the ectopic beat, frequent ventricular and supraventricular ectopic beat. These are also not uncommon in elderly patient and can often be benign. There is also a short run of atrial fibrillation, a brief episode, 5 beats is noted, but this is also not sustained. And regarding the pause, there was a 2-second pause at 5:30, but this patient was asymptomatic at that time, and this pause also occurred during the sleep, and this is also less than the threshold, less than the 3 second that would typically warrant the intervention. So we'll be going for the no intervention. So if we analyze the other options, so amiodarone, this is typically used for the management of arrhythmia, rhythm control in atrial fibrillation, or in case of ventricular arrhythmia. And in this case, the atrial fibrillation episode was very brief, only 5 beats, and this is also asymptomatic, and this is also not sustained, and it also does not seem to be the primary issue, and the patient does not have no documented symptomatic arrhythmia which should warrant the amiodarone therapy. And amiodarone also have a very significant side effect, particularly in the elderly people. The digoxin, this is generally used to control the heart rate in atrial fibrillation with the coexisting heart failure. The patient ECG does not show any sustained atrial fibrillation, and there is no features of heart failure, and her heart rate was mostly within the normal range, so digoxin will also not be applicable here. Regarding permanent pacemaker, so permanent pacemaker is indicated if the patient is having symptomatic bradycardia, or if there is a significant pause in her heart rhythm leading to symptoms like the dizziness or any features of syncope. So in this case, despite the 2-second pause at night, there is no reported symptoms like the fainting or dizziness, so permanent pacemaker is less likely. So permanent pacemaker, this is usually indicated for the symptomatic bradycardia or for the pause longer than 3 seconds in the awake individual. So it would be only indicated for a pause of greater than 3 seconds in someone who is awake with or without symptoms, or for a pause less than 3 seconds in someone who have the definitive symptoms. So awake patient with or without symptoms should be greater than 3 seconds. And if there is definitive symptoms, you can also go for permanent pacemaker even if this is less than 3 seconds, but none of this criteria is present here. Warfarin is used for the anticoagulation, typically in case of atrial fibrillation, to reduce the risk of venous thromboembolism as well as to prevent the future stroke. And here the atrial fibrillation was very short, 5 beats only. This is not sustained. The patient is asymptomatic. There is also no history of thromboembolic events, so anticoagulation is not indicated here. Also, given the patient's arrhythmia was brief, asymptomatic, not associated with significant bradycardia, or there is no features of hemodynamic compromisation, no intervention is necessary at this time. The short run of atrial fibrillation and the brief 2-second pause, they are not unusual in elderly patients, especially during the periods of sleep. And given the patient has no symptoms associated with these findings, and there was no significant bradycardia during daytime, so conservative management without intervention should be considered. And it's also essential to monitor the patient regularly, and if he starts developing symptoms, or if there is any characteristic ECG changes, then only in that case we can think of the management plan can be reassessed. So at this point we can just go for the no intervention. No
Please
intervention is.
discussion. Continue. For how many now? For how much?
We'll just continue for another one question up to 20. We're just left with one question. No intervention is the correct answer here, as the underlying rhythm is normal sinus rhythm. There is no significant paroxysmal atrial fibrillation. The pulse is less than 3 seconds. Noted to be without symptoms. Patient sleeping. Amiodarone and digoxin are not indicated, as the underlying heart rhythm is sinus rhythm. The short run 5 beats of atrial fibrillation without symptoms is not significant. Furthermore, the relative nocturnal bradycardia 2-second pause at 5:30 hour would be a contraindication to the use of either of these drugs. The short burst of atrial fibrillation is a common finding in the elderly and is not the same as paroxysmal atrial fibrillation, which should require at least 30 seconds. So it's not an indication for oral anticoagulation. A permanent pacemaker would only be indicated for a pause of greater than 3 seconds in someone who is awake with or without symptoms, or for a pause less than 3 seconds in someone with a definitive symptoms. So this would be our last one.
What is the most likely diagnosis? Acute hepatitis B, acute hepatitis C, TB infection, gonococcal bacteremia, secondary syphilis. A 21-year-old man was admitted to hospital with a 5-day history of fevers and vomiting. He also complained of knee and ankle pains. He was homosexual and had last had receptive anal intercourse 6 weeks previously. On examination, he had a widespread erythematous macular rash. His temperature was 37.5 degrees Celsius, pulse was 85 beats per minute, and BP was 115 over 60 millimeters mercury. He had no joint swelling. On investigations, hemoglobin was 147, WBC 6.5, serum urea 4.3, total bilirubin 50, ALT 687, ALP 110, and gamma GGT was 89.
So this is another difficult question. So do you think this is hepatitis B, hepatitis C, or HIV infection? What should be the most likely diagnosis?
Gonococcal bacteremia, maybe.
So the most likely diagnosis, is the acute hepatitis B. So let's go one by one. So regarding the clinical presentation, patient has comes up with the features of fever and vomiting, which is common in case of acute hepatitis. Patient has comes up with the knee and the ankle pain. It can also be seen in hepatitis infection, but this is less specific. Widespread erythematous macular rash. This can occur in case of viral hepatitis, as well as in case of in case of HIV infection, and also in case of secondary syphilis. And regarding the investigation, so patient is having the elevated transaminase, significant elevation in the alanine aminotransferase, elevation in the alkaline phosphatase and GCT, and there is also elevation in the total bilirubin. So they are also the elevated transaminases level. They are the markers of acute liver inflammation, and this type of very high alanine aminotransferase increase. This is more in keeping with the characteristic hepatitis B infection compared to hepatitis C. The elevated bilirubin is also very high. It also indicates the significant liver dysfunction, which can occur in acute hepatitis. And elevated GGT, it also indicates the hepatic involvement to some sort of cholestatic pattern. So let's rule out the other diagnosis. So regarding acute hepatitis C, so acute hepatitis C, this is commonly caused by the IV drug abuse. IV drug abuse is the most common risk factor for hepatitis C. This is rarely occurs through the sexual route, and the patient is a homosexual. Patient has an receptive anal intercourse 6 weeks previously, and this homosexuality or receptive anal intercourse, this is more commonly seen in case of acute hepatitis B compared to acute and as well as hepatitis C and as well as HIV infection. And hepatitis C rarely occurs through the sexual route. Hepatitis C can also causes elevation of the liver enzyme in bilirubin, but the acute presentation often has a more insidious onset. And acute hepatitis C generally would not have the same level of ALT elevation seen here, and the more pronounced elevation of ALT is seen in acute hepatitis B. And regarding the rash are also less common in case of hepatitis C, and they are not the characteristic pattern. Regarding gonococcal bacteremia, so they will come up with the more acute systemic symptoms with the potential for the joint swelling, and there should be features of more severe infection like the white cell count should be elevated. There should be features of pyrexia, and and the patient also does not have the joint swelling. And the rash is also not typically widespread. In case of gonococcal bacteremia, there may be just tenosynovitis, and also the liver enzyme abnormalities, they are not also typical with the gonococcal bacteremia. Regarding secondary syphilis, so secondary syphilis, they are associated with the rash and systemic symptoms, and they are not usually related to the severe elevation in the transaminase. So the features of hyperbilirubinemia and features of abnormal liver function, this is also excluding the secondary syphilis. Acute HIV infection, so this primary HIV infection, they usually comes up with the flu-like syndrome presenting with the fever, rash, and there would be systemic symptoms like the joint pain and vomiting with a history of recent receptive anal intercourse, but there is no features of fever, there is no features of joint pain. And the degree of HIV can to some extent causes hepatic involvement, but the degree of liver enzyme elevation and bilirubin increase, this is more sensitive with the acute hepatitis. And the rash in HIV, it can be maculopapular, but based on the T-range transaminases, this is more aligning with the acute hepatitis B. So the combination of high ALT, elevated bilirubin, presence of rash makes the acute hepatitis B the most likely diagnosis. Other conditions like acute hepatitis C, HIV infection, gonococcal bacteremia, secondary syphilis can also present with the similar symptom, but they usually does not exhibit the same level of hepatic enzyme elevation and the bilirubin increase here. So most likely this is our acute hepatitis B. This patient's blood results suggest he has acute hepatitis. All of the answers are plausible, but acute hepatitis is more likely to be caused by one of the hepatitis virus than by other sexually transmitted infection. Hepatitis B virus is far more commonly transmitted by homosexual and intercourse than hepatitis C virus. In the UK, IV drug use is the most important current risk factor for the recent hepatitis C virus infection. So this is the end of our first 20 questions from the RCP sample paper discussion, and we'll be most likely concluding here. So any further question from anyone? And the next session would be either tomorrow or on Thursday, but I will confirm 1 hour or 30 minutes before the session tomorrow. So any question from anyone? So if no question, we'll be concluding here. Okay, thank you.
Thank you so much. Thank you, sir.
Thank you, sir. Thank
Thank you.
Thank you.